Hello, my name is Jennifer Wallace-Valdez. I'm a physical therapist with Cure Duchenne. I am the instructor for this course and wanted to tell you a little bit about myself and my experience before we begin. My experience with Duchenne muscular dystrophy started out in 2002 with my very first patient as a licensed physical therapist. He was a young man, undiagnosed, who ended up with a diagnosis of Duchenne muscular dystrophy. Through learning everything I could about him and everything I could from the professionals and the experts in the field, I have gathered a lot of information over the last many years. And so in putting together this course, I'm hoping that I can convey some of this information and tips and tricks to you to help with your practice, to benefit your patients and the families that you serve. The objectives are that by the end of this course you will be able to correctly identify the 4 main medical tests which lead to a diagnosis of Duchenne muscular dystrophy, correctly identify the most common type of genetic mutation which leads to Duchenne. Given a patient scenario, we'll be able to correctly identify the current stage of Duchenne the patient is experiencing, correctly identify 3 body systems affected by Duchenne. Given a patient scenario, which identifies the stage of the disease, we'll be able to correctly choose 2 appropriate treatment interventions, independently develop a physical therapy plan of care for a patient in the ambulatory stage of Duchenne muscular dystrophy, correctly list 4 other healthcare professionals whose expertise is part of the standard of care for patients with Duchenne. Let's start out with the basics. Duchenne muscular dystrophy. It is the most common lethal childhood disease worldwide. At this time, there is no cure and have been no survivors, although a lot of the men are living longer lives at this point. It affects all cultures, ethnicities, socioeconomic classes equally, and it's present in 1 out of every 5,000 live male births. It is considered a rare disease, but it is not a 1 in a million. It is present in 1 out of every 5,000 live male births. Duchenne has a similar diagnosis called Becker. They are related, but here's their similarities and differences. They are both X-linked recessive inheritance. Duchenne is more common. It's 1 of every 5,000 live male births, whereas Becker muscular dystrophy affects 1 out of every 18,000 live male births. In Duchenne, 1/3 of the cases could be newly acquired mutations, meaning they weren't passed on from a parent to a child. But in Becker muscular dystrophy, the newly acquired mutations is much less at 10%. They are both hallmarked by progressive muscle weakness, although Duchenne has a faster progression. Typically, loss of ambulation these days is between 10 and 12 years old for someone who has Duchenne muscular dystrophy, although that statistic is always changing and is dependent on a lot of their care. The loss of ambulation for someone with Becker muscular dystrophy is more like 30 years old. And at this point, the life expectancy for someone with Duchenne muscular dystrophy is approximately the mid-20s, which is a big change over the time that I've been treating those with Duchenne, when it used to be the mid-teens. And for Becker muscular dystrophy, life expectancy is typically in the mid-60s. There is a difference in pattern of muscle impairment between these 2 dystrophies. Here is a diagram to help us visualize the initial onset of muscle weakness and how they are similar and different. You can see that in Becker muscular dystrophy, initially the posterior muscles of the neck and trunk and the anterior hip are affected. In Duchenne, you see that there are more muscles initially affected, such as the neck, anterior and posterior shoulder, and the trunk, and the whole posterior lower extremity. This may help us understand better why we see more significant difficulty with ambulation at even younger ages in Duchenne. In both conditions, the muscle pattern is progressive and does result in full body impairment including the diaphragm, cardiac muscle, and smooth muscle. At this time, the median survival of someone with Duchenne muscular dystrophy, as I said, was mid-20s, and that is due to ventilatory support advances and better use. Just 10, 15 years ago, the median survival for someone with Duchenne muscular dystrophy was 17 years old, and ventilatory support wasn't part of standard of care at that time. Both Duchenne and Becker muscular dystrophy are genetic disorders. So here's the genetic basis of this X-linked recessive genetic disease. So being X-linked means that it is on the X chromosome, and being recessive means if you have two X chromosomes, it will not be the dominant one, it will be recessive. So in women, on this pair that we're looking at, we have two X chromosomes. So if this is recessive, that means that our dominant chromosome would be taking over and the recessive would be there, but not prominent. For males, since they have an X and Y, if their X chromosome is mutated, it's the only one they have on that pair, and so the mutation will actually take hold. So a male with a mutation on his X chromosome will be symptomatic of Duchenne. A female who is carrying this mutation is called a carrier, and she has the opportunity or the ability to pass this mutated chromosome onto her children. So in the 4 scenarios of children where you could have an unaffected son, an affected son, an unaffected daughter, or an affected daughter, there's a 25% chance that she is passing this affected gene onto one of her children. An unaffected son means that he got the dominant chromosome that is unaffected from his mother. An unaffected daughter means the same. She received the unaffected chromosome from her mother. The affected children, if the daughter receives the mutated X chromosome from her mother, she will be the same carrier status as her mother. If the son receives the affected chromosome, then he will be symptomatic of Duchenne. Like we said before, there is still cases of a spontaneous mutation where the son is the first one in the family with the mutation. And mothers, or females I should say, who do carry this recessive X chromosome mutation can have the incidence of being what we call a manifesting carrier. It really is a 1 in a million chance, but if you have an X chromosome that is supposed to be dominant and for some reason it isn't taking over, it's not doing its job, then the recessive X chromosome will, and if it has the mutation, then that female can have the symptoms of Duchenne. So these days, we have the great problem to think about. Fortunately, a lot of our men with Duchenne are living longer and much fuller lives the way it should be. So on your screen, there's a picture of a young man with Duchenne holding his daughter. So knowing what his genetic mutation is, what do we think of his daughter's genetic makeup? If you think it through, his daughter has received his X chromosome and she's received her other X chromosome from her mother. He did not pass on his Y chromosome where he would have had a son. So his daughter would have received his X chromosome, which has a mutation on it. So she would definitely be a carrier of Duchenne muscular dystrophy. Whereas if he would have had a son, he would have passed on his Y chromosome, and the mother of the child would have hopefully passed on healthy X chromosome, and the son wouldn't have Duchenne muscular dystrophy or be a carrier of it at all. So in the past, we always were concerned when families were looking to have more children and we knew Duchenne ran in the family, we were always concerned about the sons. What if a son is born and he receives this mutation? But nowadays, we have to also think about if someone with Duchenne has children, that we know the daughter will be a carrier of it and that the sons will no longer be affected. They won't receive the mutation at all. Okay, so let's look into dystrophin's genetic basis a little closer. We have the human genome mapped out, and we know where to find this mutation that causes Duchenne and Becker muscular dystrophy. On the human genome, we're looking at the 23rd pair of chromosomes. For men, they have the XY combination, and for women, they have 2 X's. On the X chromosome, we're looking at this one small place, the XP21.2, and housed in that small area is the programming, the recipe for making one of the largest proteins in the human body, which is called dystrophin. Dystrophin is a protein, and it is formed by 79 exons that have to be lined up just perfectly, all fit together just right, in order to produce this protein called dystrophin. So if you're looking at this schematic here, you can see we have exons 1 through 79 all lined up together, all placed next to each other where they should be. If you're missing one of those or a group of those, then the remaining pieces don't come back together as well, and that dystrophin protein is not produced the way it should be. We'll go into this a little bit later as well, a little deeper. To help us understand the importance of that dystrophin protein, we're going to look now at a muscle cell diagram. This is a simplified diagram that's going to show us the sarcolemma, which is the muscle cell membrane, and then on the inside, our contractile element, which is our actin and myosin. And then in between those two is our dystrophin protein. This dystrophin acts as the anchor between the extracellular and intracellular components. The dystrophin is sometimes called the anchor. And what we need in our muscle cells is that muscle cell membrane and the contractile element to work together. And dystrophin is the protein that does that for us. When dystrophin is absent, it leaves the muscle susceptible to injury and damage. Too powerful of a contraction can cause cell wall damage, but also eccentric muscle contractions. It's important to know that we know eccentric muscle contractions are by far the most damaging type of contraction that we can do to a dystrophic muscle cell. What happens is the contractile element is doing one thing while the cell membrane is doing something else. They're not working together, so that type of tension causes microtears in the cell membrane. When those microtears occur, the membrane begins to leak. There becomes a large influx of calcium into the cell, and we know an unregulated calcium influx to a muscle cell will cause necrosis of that cell. So it's no longer a viable tissue, and then it becomes infiltrated with inflammatory deposits, adipose tissue, and just overall fibrotic additions to that area. And as this happens and keeps occurring to multiple muscle cells within the same muscle, that muscle becomes less and less active and less viable and more fibrotic. With the missing dystrophin molecule and the progressive damage to muscle cells, what we will see in our patients as primary impairments is significant weakness. Initially in hip extension, the gastrocsoleus group, interscapular muscles, abdominals, neck flexion, all these core muscles that we use all day long. And then also is muscle stiffness. So as we talked about the damage to the muscle cells, that leaves all of these patients with Duchenne muscular dystrophy prone to chronic inflammation. They live a life of this inflammatory process, and which causes muscle stiffness. As we know, the inflammatory process ends up causing fibrosis, and that in turn decreases the elasticity of a muscle cell and causes the stiffness to increase. And then building on those primary impairments are secondary impairments, which are those contractures. That's when that stiffness has gotten beyond capacity and made somebody with a contracture of a joint that will not move through its typical range of motion. The typical initial areas of contracture are the gastroc and soleus group, the hamstrings, and the tensor fascia lata. What we'll also see as secondary impairments due to the weakness and this muscle stiffness is the functional compensations and their limitations in general. And you can see these as young as a 1-year-old who's learning to walk. Activity intolerance is a big one to keep in mind, because even though they're moving through their environment and you may not see a lot of other things, especially when they're younger, their ability to tolerate a normal daily routine for a child will absolutely be involved. There's also balance disturbances. So if you're thinking about somebody who has weakness in certain areas, especially in the core muscles, some tightness in other areas, their capacity for balance reactions and catching themselves are diminished. And so the smallest thing could probably set them off of their balance, set them out of their center of gravity, and cause falls. So there are many things happening inside the body of someone with Duchenne and Becker muscular dystrophy, adding to the decline in their function and overall health. The primary mechanism, the primary pathophysiology, is that susceptibility to muscle damage, which results in less muscle viability and an overall decline in function. And the resulting chronic inflammation that they have as well and development of fibrosis adds to their decline. There's also this thing called nitric oxide synthase. We'll call it nNOS. It typically lives on every cell membrane and allows for vasodilation when the cell needs more nutrients. So in a healthy individual, when we start exercising, nNOS is responsible for the vasodilation so that we get what we need to the muscles that need it. With this being absent in Duchenne muscular dystrophy, the person ends up with what we call functional ischemia, which means while they're working, they're not getting the blood to that muscle that they need, which leads them even more susceptible to injury and poorly functioning muscle tissue. There's also satellite cell hyperactivation. So we're all born with a certain capability to produce new muscle cells. This may help keep us active and able until maybe our 30s or 40s before we realize we're really slowing down. It's harder to keep up our muscle tone and fitness. But in someone who is rapidly going through this degradation and regeneration cycle at a very young age, like someone with Duchenne muscular dystrophy, they may be burning through this satellite cell activation, their stem cell pools at very young ages, instead of allowing that cycle to last them longer through their life. So this might be why we see young boys with Duchenne muscular dystrophy still have enough viable muscle tissue and still using this cycle really well of developing new muscle tissue, so they're keeping up. You see them very active, you can maybe see them running across the room or at school and say they're doing great, they're keeping up with their peers. But just keep it in mind that what they're doing now may actually affect them in the long run if they're burning through this stem cell pool too fast. So how does someone go about getting the diagnosis of either Duchenne or Becker muscular dystrophy? We're going to go over each of these areas: clinical presentation, creatine kinase level in the blood, electromyogram, muscle biopsy, and genetic testing. So the clinical presentation of Duchenne muscular dystrophy. Toe walking is very common. If you've never met someone with Duchenne, then if you ever do, they will most likely be a toe walker. Not all are, but most do. There's also a pseudo-hypertrophy of the calves, and sometimes the deltoids, the quadriceps, and the wrist extensors. There's a Gower maneuver, which we'll demonstrate. There's waddling gait, and also a difficulty with stairs and running. So pseudo-hypertrophy of the calf muscles. What you see here is a 13-year-old healthy and active boy on the left side. He's very active in lots of sports, but typically 13-year-old boys who exercise a lot and are very active don't have profound muscle hypertrophy and large calves. So he is a very typical 13-year-old on the left. And on the right, what you see is a 13-year-old boy with Duchenne muscular dystrophy who's still ambulatory. There's a significant difference in their calf sizes. But this is a pseudo-hypertrophy of the calf muscles. What you're seeing here on the right is actually a lot of swelling, that chronic inflammation that we talked about, fibrous and adipose tissue deposits. And you can even see on the back of the calf there a little bit of glare from my flash of my camera because the skin is that taut. So just know, even as young as your 3 and 4-year-olds, you may see pseudo-hypertrophy of the calves, and that is a red flag. There's also the Gower maneuver. This is definitely a hallmark of Duchenne and some other diagnoses. The Gower maneuver was identified way back in 1879 by Dr. Gower, and it was basically a way of getting up off the floor that was not a typical way. It involved very laborsome maneuvers of rolling over to the stomach, getting up on all fours, and then up onto like a bear stance on the hands and feet, and crawling the hands back up the legs until they're up into standing. And what we can show you here is that even this 3.5 to 4-year-old boy in the picture here who has Duchenne muscular dystrophy is demonstrating that. That's how he gets up off the floor, using his arms on the floor and then one of his hands on his thigh to get himself up to vertical. To give an example of the Gower maneuver, we have a video here of a very typical Gower maneuver performed by a young man with Duchenne muscular dystrophy. Typically, when someone with Duchenne gets up from the floor to standing, they'll begin with rolling to their stomach. This individual uses his momentum to get his head up off the floor, grabbing onto his legs, but then quickly rolls over into quadruped. From this hands and knees position, he's trying to get his feet under him until they're stable. You can see him working very hard at this. and finally getting them to a point where he feels that they are stable enough to try to walk his hands back towards them. You see he has a wide base of gait, which goes from more of the sagittal plane to the frontal plane, but it's where he feels significantly stronger. He'll walk his hands back towards his legs, place both hands on his left thigh, and then push himself up into extension using his arms to assist. What you also might see, some of the subtle compensations that are really common, is to watch out for circumduction of the trunk as they go from hands on the legs or hands on the floor up to standing. So they're avoiding sagittal plane movement where they would have to use their hip and trunk extension. They'll do circumduction to avoid that. And also at that very last moment of extension, watch for plantar flexion, because that's another very common compensation that they use to force the hips forward to get the body back and up into extension. Gower maneuver involves so many muscle groups and joints that it's actually a very good and very sensitive measure for us to use to detect change in their condition over time. So if you're watching someone do their Gower maneuver from one point from a baseline to 6 months later, you should be able to notice changes in their condition and also the amount of time that it takes to complete it. It's important to say that Gower maneuver does not indicate specifically Duchenne muscular dystrophy or Becker. It simply means that this person has proximal muscle weakness, so it is not a definitive diagnosis based on this maneuver. So here's a young boy with Duchenne as well, and he's going to show us his Gower maneuver, but watch quickly, because he does it very quickly. And what you just saw there is still considered a Gower maneuver, although it looks really different than the first example. This young man is able to start out by rolling over to his hands and feet and then can really pop up quickly without all the laborsome maneuvers that you may have seen in the other video. Another one of the clinical presentations of Duchenne is waddling gait. This is how you describe somebody who's walking with a wide base of support, very short step lengths, and has very limited balance reaction capability and limited activity tolerance as well. So you'll see this where he's taking short steps, lots of lateral shift of the trunk, and probably some insecurity. Like in this video, you see his mother walking with him to assure that he doesn't fall or trip. Another clinical presentation is the Duchenne jog. It has its own name because most of the time, in almost every case, boys with Duchenne never experience a true running pattern. So it's called a Duchenne jog. It's a very typical part of one of the tests that we'll discuss later is to do a 10-meter run, and what you'll typically see is this Duchenne jog. So in a Duchenne jog, what you probably are missing seeing is a moment of flight. They'll almost always have at least one limb on the ground. They'll get that forward momentum going, but then they also make all these adaptations to keep it from being too much momentum. So you'll see them maybe have an upright trunk instead of forward, a lot of shoulder swing to help balance it, and then shorten their stride just a bit so that they can control the landing of the forward limb. To get further into the diagnostic process, there is a serum creatinine kinase blood test that can be done quick and simple. Most people have had it done at their doctor's office for one reason or another, but it's one of the signs in Duchenne muscular dystrophy that can lead to a further diagnostic process. So normal CK level in an individual is less than 160 IUs per liter. In Duchenne, this increase is significant. It's typically 50 to 200 times that normal range. A typical range can be 15,000 to 35,000. So if a blood test is run and Duchenne wasn't on the radar, they'll usually think that this test had come back in error and run it again and say there's no way it can be that high. If Duchenne is suspected and this comes back, then they'll quickly move through the diagnostic process once they get this result. In Becker muscular dystrophy, it's important to note that they will also have a high CK level, but it won't be nearly as significant as Duchenne. More like 10 to 20 times normal, so a reading right around 1,600, something like that, maybe 2,000 is more typical for someone with Becker. So still would set off red flags, but not as blatant as someone with Duchenne. And then there's also those carriers, a female carrier of the mutation, 70% of them have an increase in this CK level as well. So many times in hindsight, There can be a woman who has always had a high CK level, maybe about 2 times of normal, but no ever real reason why, until she has a son who gets diagnosed with Duchenne, and then they look back and find that she is a carrier of that mutation. Electromyogram is in this course to address it because it used to be part of the diagnostic process. It's no longer the standard of care, but I want you to understand it just in case you see it in other readings. So EMG is used to differentiate other neuromuscular disorders, but in Duchenne, it has a normal motor and sensory signal velocity and doesn't demonstrate any denervation. So it doesn't get you any further into a diagnostic process at all because you get a normal result. So to help with diagnosis, muscle biopsy may be done. It can be open incision, which is typically about 1.5 inches, maybe 2 inches of an incision where they go in and get a sample of the muscle, or a needle biopsy where the tip of the needle is open. They put it into the muscle area and turn it to get a small sample. And what they're looking for is the condition of the muscle and what else is in that sample. So if you look at the slides here, you can see the first sample is a normal muscle sample under microscope. What you see here that is normal is very tightly packed in muscle cells. They're very close together, they're functioning well together. And then you do see some of the white, which is fascia, a little bit of connective tissue, maybe a little bit of adipose tissue, which is completely normal. And all of the muscle cells are basically the same size, same color, and packed in very close together. The second sample that you have there is someone who has mild amount of damage in this area that was biopsied. So you can see the difference in the muscle cells themselves. They're not packed in tightly. They're different sizes, different shapes, even different colors. Some of these really dark ones are actually necrotic muscle cells. So they have no viability anymore, are not adding to the contractile force at all. And so there's also a lot of that white stuff, the infiltrates. So we've got adipose tissue, you've got connective tissue deposits, a lot of fibrotic changes happening in this sample, but there's still some viable muscle cells. The third example is actually someone who is significantly involved with muscle damage of some kind. So when you look at this one, you see large areas of adipose tissue deposits. There's a lot of swelling and edema between muscle cells, and you see very few that are probably functioning muscle cells. So the ones that are dark, that have a thick rim around them, they probably are not viable muscle cells anymore. And it's important to note, with a muscle biopsy, it gives you some information, but not full information. It's only giving you information from where that sample was taken. So if they took it from one piece of my bicep, you may see the second slide if I had Duchenne. If you take it from 1 inch away, you may see the third graph where there's a significant amount of damage. So this sample is very dependent on where it was taken from. The real value of a muscle biopsy is when they stain it for dystrophin, and it's called immunofluorescence microscopy. So they'll look at it under a microscope that's specially adjusted to look for this glowing dystrophin in muscle cells. If you look at a cross-section of a muscle sample, you should see a green glow around every single muscle cell in a healthy individual. That is saying that every muscle cell has dystrophin in it. In these samples here, BMD stands for Becker muscular dystrophy, and the top line is 4 individuals with Becker muscular dystrophy. And you can see there is a large variation in how much dystrophin these individuals have. Some look like they have almost all, and some are missing maybe 50% or so. And you can tell by the blackened areas where there either isn't a muscle cell or the muscle cell that is there is not glowing with dystrophin. On the bottom line are 2 individuals with Duchenne muscular dystrophy. One of them has a small amount of dystrophin glowing, and the other one really doesn't have any at all, meaning they have no dystrophin production. And so this is where the value of that muscle biopsy really comes in. So you can look at this and say, do they make dystrophin at all? Is it going to be partially functioning? And try to get a better estimate at what their prognosis would be and their phenotype, how severe their progression might be. The hallmark for diagnosis of Duchenne muscular dystrophy is genetic testing. All of those other things that we just talked about, Gower maneuver doesn't mean you have Duchenne. It just means you have proximal muscle weakness. The muscle biopsy doesn't tell you have Duchenne. It tells you have muscle damage. All of those things lead you in this direction. But what you need to have done is genetic testing to get your definitive diagnosis of Duchenne. There are three main categories of gene mutation that we're looking for when a genetic test is done. And this is simple and easy. It can be done from the same blood sample that they did that CK level from. They can send that into the lab and get the genetic testing done. It's a very non-invasive test. So the three gene mutations that we're looking for are point mutation, which is up to 25% of individuals with Duchenne. Duplication is a mutation for about 10%. And deletion is our largest category for 65% of those with Duchenne. So to describe what each one of these are, a point mutation, if you can recall back from learning about genetics, we have these nucleotides that make up our DNA, and they come in groups of 3, and they have to be in a perfect exact order when they are being produced and read by the messenger RNA and produced as new DNA. So in Duchenne, or in the dystrophin protein, we know that when there's a long formula of these nucleotides, when there's a TGA, that triplicate right by itself, that sends a stop codon, and that messenger RNA is sent off to become a dystrophin molecule. But if for some reason there's one tiny point mutation, maybe a C is switched to a T, so now instead of a CGA in the middle of this formula, a TGA appears. And it's not at the end where it should be, it's somewhere in the middle. That stop codon happens again because that signal of TGA was there, and then this smaller recipe is sent off to become dystrophin, but it does not because it's not the full formula. It's like trying to cook chocolate chip cookies and you don't add all the ingredients in before you mix it up and put it in the oven. You don't end up with the cookies you intended for. And same thing when you're trying to produce a dystrophin protein. If you don't have the entire recipe, you don't get the dystrophin that you're trying to produce. Then we have duplication mutations. This is when you have those 79 exons that we mentioned before, and one or many of them have been duplicated. They have too many exons in this reading frame, in that formula that we talked about. So a duplication would look something like this. If they had a diagnosis of a duplication of exons 2 and 3, their reading frame would be 1, 2, 3, 2, 3, 4, 5, 6, 7, and on down to 79. Or it could be a large area of duplication. They could have a duplication of exons 25 through 45. But just know that whether they have one duplication or multiple exons duplicated, it doesn't necessarily mean a more progressive or a worse outcome, worse prognosis. And then deletion mutations, same idea, just the reverse. They don't have enough exons. So either one exon or multiple exons have been deleted from the reading frame. Someone who comes in with a Duchenne muscular dystrophy with deletion of exons 2 and 3 would have a reading frame that went from exon 1 to exon 4 and then on. And again, it's the wrong reading frame. Not everything is there. So most of the time, no dystrophin will be made, or sometimes a partially functioning dystrophin will be. It's important to understand that the number of exons either duplicated or deleted does not indicate a more severe disease course or phenotype. Sometimes there are still enough parts of the gene in that reading frame to present a partially functional dystrophin protein, but typically none will be produced. In our first example, this is a naturally occurring deletion of exon 45. And you can see this is going to produce what we call an out-of-frame mutation. So the puzzle pieces that are left when exon 45 is deleted cannot come together, do not fit together, so they cannot produce that dystrophin protein. A person with an out-of-frame mutation like this would end up with a diagnosis of Duchenne muscular dystrophy. If the deletion had been exons 44 and 45, then the puzzle pieces that are left over could have come together, hopefully, and produced an in-frame mutation, which would hopefully produce at least a partially functioning dystrophin molecule, and this person would have ended up with a Becker muscular dystrophy diagnosis most likely. Our second example is a naturally occurring deletion of exons 48 through 50. You can see the puzzle pieces that are left over with 48 through 50 gone cannot come together. So again, this is an out-of-frame mutation and would be a Duchenne diagnosis. If the deletion had been 48 through 51, the puzzle pieces that are left over could potentially come together and produce an in-frame mutation and hopefully a less severe phenotype, less severe prognosis, and a diagnosis of Becker muscular dystrophy. Some pharmaceutical development is based on this concept of trying to make an out-of-frame mutation into an in-frame mutation, producing an individual with a less severe phenotype and progression. So it's very important that patients know their mutation. Now that we've discussed how someone with Duchenne muscular dystrophy gets diagnosed, we're going to talk about the progression of Duchenne muscular dystrophy. There's a progress phase where there's evidence of new gross motor skills until about the age of 6 years old, but that is approximate. And then at that time, there's a plateau hit where those with Duchenne will probably not gain any new skills. If they had learned to jump, they probably won't learn skills on top of that. They won't learn new skills, but they're not losing any skills either. They're maintaining. They may use compensations, but they're still getting their needs met, and they're still getting through their day the same during that plateau, which is typically about 6 to 8 years old. And then after that is the decline. So that's when you start seeing the progressive weakness and the loss of function. We have a couple ways to look at the milestones and the progression of Duchenne. Here we have the ambulatory milestones in the order of loss. So if they were ever able to jump or hop or run, you'll see them lose that first. And then from there, they might get up using the Gower sign, but then after that is loss of the ability to stand from rising from the floor. And then all the way down to not being able to climb stairs anymore, their loss of ability to get up out of a chair in a typical way, until they lose their ability to walk and then ultimately lose their ability to even stand in place or to help with transfers. And then there's non-ambulatory milestones after that. The non-ambulatory milestones and the typical progression of loss is the loss of ability to first reach overhead and then reach to their top of their head, to reach to their mouth to feed themselves, and then to do tabletop activities. So in that order of limiting their abilities. And there's also some functional pulmonary function testing that goes along with those milestones as well in the order of loss. To help us as therapists try to predict what to expect from a patient that we've evaluated, we'll talk about the tests later, but these graphs here are based on the 6-minute walk test and the North Star ambulatory assessment. The first one, the Mazzone from 2013, this graph here is to help us to understand if we test somebody on a 6-minute walk test today at baseline, what do we expect 2 years from now? So the blue parts of the bars are those who are non-ambulatory, and the red portion of the bars are those who are ambulatory after 2 years. So if you look at the bottom, you're looking for the distance that they walked during the 6-minute walk test. If someone at baseline walked less than 250 meters at baseline, you can see by the blue and red that you'll have a 50% expectation rate that they will still be ambulating 2 years later. But if you go further down and somebody walked more than 330 meters but less than 350, now you have 70% chance that they'll still be walking after 2 years and only 30% chance that they will become non-ambulatory. All the way to our last bar there is somebody who walks greater than 370 meters at baseline. You can almost assure that they'll still be walking 2 years later if they're following the typical progression of Duchenne. These studies are based on natural history results. The graph at the bottom, Payne et al. Of 2014, this one also looked at 6-minute walk test and North Star ambulatory assessment. One of their most significant findings is that if you have someone who walks greater than 350 meters at baseline on the 6-minute walk test and is also under 7 years old, you can expect them to increase their ability over the next 2 years before having a slight decline in the 3rd year. Whereas even if they walk over 350 meters at baseline, but they're over 7 years old, you're not going to expect any significant gains. You will only see a decline, although it may be a slow and steady decline. But that age of over and under 7 years really makes a big difference when you're comparing it to their baseline measures on the 6-minute walk test. And we also have some information from a Henriksen article, and they really helped us show the progression, the natural history of a lot of those functional tasks that we're looking at. So what we were able to see from some of their graphs is that someone who is 10 to 12 years old will have a 50% chance of continuing to be able to get up out of a chair at that age of 10 to 12 years old. Whereas by 16 to 18 years old, it was only right around a 10 to 12% ability. And some categories such as independent walking for our 10 to 12-year-olds, it was about 50% chance that they're still walking. And then you get into 13 to 15-year-olds, it's only about a 45% chance, and then it drops off significantly from there. We're only just above 10% of individuals who are 16 to 18 years old with Duchenne are continuing to walk. So the mobility stages of Duchenne are probably the most commonly used ways that we refer to the stages of Duchenne. They're the mobility stages. They're based on the amount of mobility they have. We have the early ambulatory stage, which is the young guys, our toddlers and preschoolers. We have mid-ambulatory stage, which is approximately our 5 to 8-year-olds, the ones in that plateau type of phase. And then there's the late ambulatory, or also known as the transitioning stage, and that's approximately that 8-year-old to loss of ambulation. But again, these ages are all very approximate and changing all the time. Then we also have the non-ambulatory stages, which can be further divided into early, mid, and late non-ambulatory stage. And there's a big difference between somebody who's in the early non-ambulatory stage, who's just lost their ability to walk, versus somebody who has lost their ability to walk 10, 15 years ago and would be in the late non-ambulatory stage. So here's just a few samples of what these functional activities look like in the different stages. So we have an early ambulatory stage, young man getting up off the floor, and a late and transitioning stage, young man still trying to get up from the floor. Next to that, we have what an early ambulatory individual climbing stairs looks like versus somebody who's in that either mid to late or transitioning stage. We also have a Duchenne jog in the upper picture, transitioning into a waddling gait because he's no longer able to jog or run. And then we also have our non-ambulatory stages. So early non-ambulatory stage, still sitting upright, great, in the power chair without a lot of other devices, versus our late non-ambulatory stage in the last box there. So let's talk about each stage. The early ambulatory stage is where the symptoms are much more mild, but they are most likely present even in infants and toddlers. There's a lot of times a delay in gross motor development. Typical walking for someone with Duchenne begins around 18 months old, whereas we know with typical children it's about 12 months old. They're falling more often than their peers during this early ambulatory stage. So we know that new walkers fall a lot, but those with Duchenne continue to fall a lot more than their peers do. From the very beginning, they may have trouble with floor to stand transfer. So they'll start doing their Gower maneuver very young. It's intuitive that this is an easier way to get up, and so they'll continue to do a Gower maneuver or portions of it at a very young age. The mean age for diagnosis at this time is between 4.5 and 5 years old. And so it's usually during this early ambulatory stage when things are being noticed and the diagnosis occurs. But they may also have additional global developmental delays, including verbal developmental delays, and that might delay their Duchenne diagnosis as well. If they have a concurrent speech delay and they're maybe in an earlier intervention class or autism diagnosis, and then that might delay their Duchenne diagnosis because everything that everyone is seeing is being attributed to a different diagnosis. So there is a delay of diagnosis, and it is a hot topic in the Duchenne world. It has been for a while, and it continues to be. The newborn screening that happens when babies are born does not include Duchenne muscular dystrophy in all states except for one. And so we're trying everything else we can do to try to get diagnosis earlier, getting early intervention specialists up to speed, pediatricians, because what we have found in some historical studies is that symptoms were noticed as early as maybe 2.5 years old, and then the primary health specialist sent the child maybe to physical therapy or something like that for developmental delay, and it was more than a year later before a referral was made for that child to see a neurologist. Once that child saw the neurologist, it was usually within about a month that they received they had a CK test and received their diagnosis very soon after. So if we could speed up that process and get them to the right professional as soon as possible, we can probably decrease that age of diagnosis. Then there's the mid-ambulatory stage. So these are our guys who have built up all the skills they're probably ever going to have, but they're not losing any either. They're getting through their day, they're doing it their way, and accomplishing the tasks they need to. But mid-ambulatory stage is more hallmarked by some clumsiness, what others will call it, falling a lot, or fatigue, getting through their day, but having some repercussions from it. The fact that they're slower than their peers has become much more apparent. So these are the guys who their friends have now joined a soccer league and baseball and football, and they're playing on the weekends, and the fact that these guys aren't keeping up is very apparent by this time. Waddling gait is just beginning. If it wasn't already present, then they're probably starting to show that wide base of gait and that lateral shifting. The difficulty with running and jumping is becoming much more apparent during this phase too. And then if they were a toe walker, it might be persisting through this phase. And we'll talk about toe walking in a little bit in our therapy approaches. And then a Gower's maneuver, like I said, even if it can be present very young, and then it can continue through. And even if it's just a partial Gower maneuver during this phase, it's definitely present by now. Then we have the late and transitioning stage. This is a stage which comes on when someone is no longer maintaining their functional level. They were holding their own before, but now those compensations that they were using before are starting to fail. Their weakness has progressed. This is probably the fastest stage out of all of them, where we have to constantly try to adapt and modify their routine to address any areas of concern before they become a big problem. So the compensations that they were using for ambulation are probably failing them now. Ambulation has probably become inefficient and unsafe. And we do know that there's a high incidence of fractures in those with Duchenne, not just because of the steroids and that side effect that we discuss, but also we know that fractures happen during ambulation and during the non-ambulatory phase. We do have a study that tells us that 21% of people with Duchenne have fractures. 40% of those fractures happen between 8 and 11 years old. 47% happen during independent mobility, and 30% happen during non-ambulation to wheelchair-dependent individuals, most of them happening during physical therapy sessions or during transfers or in performing ADLs. So watch out for fractures in this stage. Someone who is ambulatory but having difficulty with it, if they suffer a lower extremity fracture, it could put an end to their ability to walk. During the recovery phase and the disuse muscle atrophy or the pain, any of those parameters change during the fracture period, they may not be able to walk again afterwards. So during this phase, late and transitioning phase, even without a fracture, they do require alternative means of mobility. If they didn't have something in the earlier stage in order to help them conserve energy, they do need something now, or they may need something very different now, because you're always planning for that non-ambulatory phase because we know it's coming. We'll also notice that they have greater difficulty with independent functional activities. If they can still get up off the floor, they'll have more difficulty with that. Same thing with stairs or getting up out of a chair. The lower extremity contractures may be increasing greatly during this phase because of all the new compensations, the new positions in standing, and the amount of time that they're spending sitting down, all adding into the hip, knee, and ankle contractures. And they will also start demonstrating an increased difficulty with completing their ADLs or needing more assistance with bathing and dressing. Here are a couple videos to give us an example of the same functional task at the different stages of Duchenne muscular dystrophy. You see our young boy in the early ambulatory stage asked to jog 10 meters, to go as fast as he can, and he takes off and keeps his momentum going, although has very short times of flight. And then you see our mid-ambulatory Duchenne jog, again doing his 10-meter timed test, and you can see he's controlling his momentum a little bit more. He has that upright posture, shorter step length, a lot of overuse of his upper extremities. And then our last example here is in the late ambulatory phase. It's more of that waddling gait because he can't add speed to it. And you can see the tremendous amount of deviations and compensations that he's making for weakness and contractures and just to steady his balance. So the non-ambulatory stage is one where we have a lot that we need to do for and offer to our patients. So the non-ambulatory stage is definitely hallmarked by increased contractures. So we've talked about the lower extremities a lot with all those compensations and the ankles and the hips and all the tightness, but the upper extremities get very involved and pretty early on in the non-ambulatory stage. So now you have somebody who, without even thinking about it, was using their arms through the day, or their arms were hanging at their side, they're pushing doors open, they're reaching for things, and now they're non-ambulatory. They're sitting in a chair most of the day, and their arms are at their side, their elbows are bent on an armrest, something like that. So the arms get much more involved. They have a decreased level of activity. So now disuse muscle atrophy is an issue. We always worried about them overdoing it before, and now we're worried about the opposite end of the spectrum. We're worried about the disuse muscle atrophy. So you have someone who is more sedentary because they can't walk anymore, but that doesn't mean that their muscles just went away. They need to find ways to still do a little bit of activity to preserve what muscle mass that they do have. They have difficulty accessing their environment, so they're no longer up and moving about where they can reach and do things. They're sitting back in a chair, and they really need a whole team approach to assess what their new environment is, what their mobility equipment is, what kind of access issues they're having to help solve all these problems. We also have a study that helps us understand why it's so important to address issues when they're ambulatory, because once they become non-ambulatory, we know that asymmetries in the pelvis and the spine when they're ambulatory actually cause a greater increase in severity and onset of scoliosis for those once they become non-ambulatory. So there is correlations between that as well. We're going to take a little bit of a break from discussing the progression of Duchenne to help you understand some of the other medical interventions and all that may alter the course of the disease for some of those with Duchenne. And the first one that you have probably heard about, or at least will a lot, is steroids and the use of steroids with Duchenne muscular dystrophy. The group of steroids that we're talking about is the glucocorticosteroids, not anabolic steroids, not the bodybuilding type of steroids. These are the same ones that you've heard of, maybe a prednisone, and the other real common one is called deflazacort, otherwise known as Emflaza. And these steroids are being used as a standard of care and have for a long time. And the mechanism is not completely understood from everything I read and people I talk to. But what it is known is that the anti-inflammatory effects that the steroids have are helping to reduce the sequelae of interactions after muscle damage, and also helping to preserve the muscle against damage as well. So there have been studies upon studies upon studies about steroids with Duchenne muscular dystrophy. There's very good studies, randomized controlled studies, and what they've been able to do is try to hone in on the best steroid to use and the best regimen to use, and one versus the other. So we have prednisone versus control studies, and we have deflazacort or Emflaza versus control, and then there's a couple studies that are also prednisone versus deflazacort versus control. So we're going to go over a couple of them so you better understand what it is that you would expect from a patient who has been on steroids. Also is important to know the standard of care, the Bernkrat from 2018 articles that are in your references, the Duchenne muscular dystrophy guidelines also help us to understand that steroids are standard of care, and that that document and most physicians you speak with, the neurologists that treat Duchenne, typically agree that the age of 4 years old is a good time to begin using steroids. But let's talk about them individually. So we have the prednisone versus control studies. There's one that's known as the Pradhan study from 2006. And what they did is give a typical dose of prednisone, and they were measuring many things, including fall frequency, peak expiratory flow, time tests, muscle strength. And what they found in their results was that after beginning steroids, the prednisone group had their maximum improvement 2 to 4 months after beginning the steroids, and that the fall frequency decreased by 97% over 1 year. And we know that falls are a big problem in Duchenne, so being on the steroids decreased that fall frequency 97% in their treatment group. Peak expiratory flow improved 42% at 6 months, and all the time tests improved between 43 and 51% at 6 months as well. All these improvements that they found were maintained for about a year. The other study listed here, prednisone versus control, is the Yilmaz study from 2004. They had 66 individuals with Duchenne in the treatment group and 22 individuals with Duchenne in their control group. They did a prednisone versus control for about 2.5 years on prednisone. After that, the treatment group had no incidence of scoliosis at 11 years old, whereas the control group, 7 out of their 22 individuals had scoliosis at 11 years old. And then let's move on. Okay, so in prednisone versus control, every study you look at, whether it be functional tasks or scoliosis, every study finds benefit of prednisone versus control. Deflazacort versus control was studied by many. One of the bigger studies is the Bagar study, and they did deflazacort versus control. They looked at function, cardiac tests, pulmonary tests, and overall survival. And what they found was that 70% of those in the deflazacort group at 10 years old could still get up from the floor, whereas only 17% of those in the control group could. So a big difference between 70% that could and 17% that could only in the control group. Other things they found was the stairs, that treatment group, 70% of them could still go up stairs at 10 years old, and out of the control group, only 6% could. A lot of other results that they found, but one of the ending results that they found was 35%, at the end of this study, 35% of the control group had passed away, and only 5% of the treatment group had. So we got good results, prednisone versus control or deflazacort versus control. So then, of course, everybody wants to know which one's better. Should we be on prednisone or should we be on deflazacort or Emflaza? So there's many studies that compare the two and then compare them to the control group. There's 3 of them listed here just to give you a couple details from each one. The Balaban study is actually a retrospective study, and they found that all of the steroid groups, whether it was prednisone or deflazacort, had better functional results and less incidence of scoliosis versus the control group, and that there was no real difference between deflazacort and prednisone in their study. The side effects were different though. So the main side effect found with deflazacort was cataracts, and the main side effect found with prednisone was hypertension, behavioral issues, and weight gain. Both groups had an increased incidence of fracture. The Bach study in 2010 was a little bit more recent, but they also showed that in ambulation, that being on either of the steroid groups increased loss of ambulation from 9.7 years to 10.8 years. It postponed the need for non-invasive ventilatory support by 3.7 years later, and on about the benefits of prednisone and deflazacort versus control. But both drugs were beneficial. And then the last one that we've added in is the Grigg study, which was published in 2016. It was actually completed in 1995, but it just got published because of the need for the information. And it was a randomized controlled trial. They were on 12 weeks of deflazacort at 2 different doses, so 2 different groups. Each of one of them had a different dose, and then a prednisone group. And both groups had better strength after 12 weeks versus the placebo. So prednisone and deflazacort both had better than placebo. But what they did find was that deflazacort had significantly less weight gain than prednisone. So there's a lot of studies out there. There's tons you can look at if you want more information on that. But just know that all of the studies have shown benefit over no steroid at all. So some of the other interesting things about the progression of Duchenne and the influence of medical care right now is we can see that back prior to a lot of treatment in the 1960s when Duchenne was being diagnosed, the loss of standing, loss of ambulation happened very quickly. The loss of ability to self-feed, maybe around 14 years, and the life expectancy was less than 20 years. And then they started adding in some treatments like spinal surgery for the scoliosis and adding in ventilation later on. And so that helped postpone the incidence of respiratory failure and death a little bit later, closer to 20 years old and on. And then now, with the addition of steroids, improved cardiac management, continuing with scoliosis surgery and ventilation as needed, we've moved all of those losses further out in life. So loss of standing happening later, loss of ambulation happening later in life, the need for ventilation not until later, and then the age of death being in the middle 20s as the life expectancy now. Looking more at the benefits of steroids within function in areas that we would look at our patients for. There's a study by Henriksen et al. From 2013, which gives us a lot of information on a steroid naive group versus those who are on steroids and their ability to still complete tasks. So we look at things like standing from the floor to getting up from supine, and if in their groups, if you had never been on steroids, by the age of 10 to 12 years old, there was zero chance of you still being able to get up from the floor. But if you were on steroid regimen, then there was still 40% of individuals getting up from the floor independently. And same thing with climbing stairs. Those who had never been on steroids, only about 30% of them were still able to go upstairs at the age of 10 to 12 years old, whereas about 50% of them who are on steroids could. And then by the age of 13 to 15 years old, the only ones that could go upstairs anymore were ones who were on steroids, even though it was only about 30%. That was 30% of individuals that still could. And same thing, rising from a chair. If you've never been on steroids by 13 to 15 years old, then none of their participants were able to still get up from a chair independently, whereas almost 40% of those who were on steroids could still get up from a chair. There's also a great study about performance of upper limb tests, which we'll talk about in a little while, that shows that the steroid regimen actually improved the results on their upper extremity tests as well. Pulmonary and respiratory care is a big topic for our patients with Duchenne, and there are things that we as therapists can do to help them. The early training for effort of blowing is actually a really important thing that we can do for young boys with Duchenne. So it is standard of care for them to start pulmonary function testing as young as 7 years old or when symptoms begin. But if a 7-year-old goes into a pulmonologist's office and tries to do their maximum effort to suck, to blow, to do it quickly, to do it slowly, all those commands that they get, and that's the first time they've ever done it, they may not get very reliable results. So we as therapists can add it into our treatment regimen where we're teaching them about these blowing and inhaling and holding their breath techniques to help them improve their results. And also, this is stuff that we can keep doing with them, respiratory exercises throughout all of their stages of Duchenne. So those things, like I said, blow, inhale, and breath hold are very important. And swimming is something that we can introduce the idea to them if they haven't already. Might be a really enjoyable way for them to work on their respiratory health as well. Some of the treatment techniques that can be used to help them with their respirations, with pulmonary health in general, is assisted coughing, which can be done manually or with an ambu bag or a cough assist machine. It's typically prescribed by the pulmonologist and carried out by the respiratory therapist a lot of times, but if you have some interaction with it, you can actually help and intervene. There is a technique called breath stacking, which is really an easy technique to help someone increase the capacity, increase their inhale, their inspiration of their lungs. So if they have poor chest wall mobility or their diaphragm is weakened, you can teach them breath stacking to help them clear their throat to produce a cough because they don't have the strength to produce pressure behind their epiglottis. So what you would do really simply is ask them to take that deep breath in, which is probably a shallow breath to them. Tell them breathe in, hold it, breathe in again, and keep holding it. Don't blow it out in between breaths until they've stacked multiple breaths together, and then cough it all out all at once. So they've built up pressure behind that epiglottis, and then they're coughing it out to help clear their throat to get that mucus out, which if they start to get a cold or any sort of infection, they can use this to help clear their throat, because that is a big issue too of a simple cold becoming a pneumonia, and if they don't have a cough assist in place yet. There's a lot of additional respiratory references out there, and some of them very specific for physical and occupational therapists to help the patients with. The Kessler article, which is listed here, is an article where they did 2 years of inspiratory muscle training to 27 subjects, and their treatment groups increased from their baseline vital capacity measures. So you could read over this of what their protocol was and what results they got if it's something you might be interested in. There is a respiratory care of the patient with Duchenne muscular dystrophy, which was put out by the Thoracic Physician Society American Thoracic Society. And so that gives us more information on the care of a patient. But then the Lamora article is also listed here. That's the one I was just referencing. And just to give you more of their results, they actually, they did resistive breathing to train the diaphragm, and 10 of their 15 patients increased respiratory strength after 6 months, and then they maintained it for 6 months after the training was completed. And then they also saw that inspiratory muscle training as a pre-op training can increase pulmonary function test values by 25%. So you can read that article if you're interested in adding this to your practice as well. Another area of importance to those with Duchenne, and something that you might hear a lot about, especially a lot of the parents are very networked with each other, and they may hear, Johnny Smith is taking calcium, should we be taking calcium? Well, they're taking green tea extract, what does that do? So there's some common ones, and there's some that you've never heard of before. I'm going to give you just a list of a few of them. We obviously don't support one or the other than any information or research, good research that has been done on any of them, but just to give you a better understanding of what you might hear. There is the creatine monohydrate, which at a low dose you may see increase in strength, but at higher doses it can cause kidney damage, so they need to be very careful with that. The glutamine, there is a high turnover in muscles and protein for Duchenne muscular dystrophy, so their overall protein levels are always low. So supplementing shows some short-term protein sparing. But the research on that has gone back and forth, so that's why we're questionable about it. Some of the vitamins you may hear about is vitamin E, which true for all of us, helps reduce oxidative stress. And remember, we're talking about individuals who are in a chronic inflammatory state their whole lives because of the muscle breakdown. So reducing that oxidative stress may be beneficial. Vitamin D for bone health. So when we're talking about steroids, one of the primary side effects, detrimental side effects of steroids is the loss of bone, and so the development of osteoporosis and things like that. So if the physician has tested them for their vitamin D levels, find they're deficient, vitamin D may be on their daily regimen as well. Calcium is on your next list under supplements, and same thing for bone health. So the addition of calcium may be warranted and instructed under their physician's care. The coenzyme Q10 is an antioxidant. It reduces that oxidative stress, but it's also been shown to enhance cardiac output in patients with CHF. And fatty acids and green tea extract are both ones that you may hear used, and just like any of us would use them for that anti-inflammatory and that antioxidant capability of those things as well. So there's a couple articles listed here if you want to read more about them. They're from nutrition journals, so I would recommend that, as well as a referral to a registered and licensed dietitians to help them with this as well. There are also many people with Duchenne who also present with learning disabilities of some kind. So it's approximately 30% of those who have Duchenne muscular dystrophy will also have some sort of learning disability. There's documented findings of all of these that are listed here: speech and language deficits, short-term verbal memory, phonological processing, cognitive delays, autism spectrum disorders, attention deficit hyperactivity disorder, and obsessive compulsive disorder. There's been multiple studies and multiple publications about this, and what we do know is that dystrophin is also present in the brain, not just the muscle tissue. It's present in the brain, but it's not progressive. So if you do have somebody with a learning disability, possibly because of their lack of dystrophin, hopefully that means it won't be a progressive disability. It's just something that they will deal with or learn to adapt to. There's a couple studies that we can mention here that do highlight especially the autism spectrum, the ADHD, and the obsessive compulsive disorders. And the Hendrickson article compares the general population to the Duchenne population to show that it is more, all of these are more prevalent in Duchenne versus just the general population. In the attention deficit hyperactivity disorder, the general population is approximately 7%, and the Duchenne population almost 12%. Autism spectrum disorder, general population is approximately, it says 2.4% currently, and the Duchenne population, 3.1% of those with Duchenne would have somewhere on the autism spectrum. And then obsessive compulsive disorder, general population is 2.3%, whereas our boys with Duchenne are 4.8%. It's important to also recognize that they haven't found a relationship between like attention deficit disorders or hyperactivity disorders and glucose corticosteroid treatment. So some of the behavioral side effects of steroids shouldn't be confused with any of these learning disabilities. And sometimes somebody will have a learning disability and their behavior that is being noted isn't because of the steroids. So it's important to try to delineate between those two. When we began talking about therapy evaluations and interventions for Duchenne, it's important to note that the guidelines that were published in 2018, the lead author is Bernkrant. You'll find it in your references. They do state very specifically that PT and OT should be involved in direct patient care from the time of diagnosis throughout lifespan. So there's a lot for us to go over in regards to evaluation and intervention. We'll start with the subjective evaluation. In my typical subjective evaluation, what I'm going to go over first is their general health. Just because they have Duchenne muscular dystrophy doesn't mean that they don't have other conditions as well, and I need to know about any of them that may influence our treatment plan. I also am asking them about their developmental history. Did they have any developmental delays in any other areas, gross motor development as well? And any previous therapies is really important to know too. So as I'm doing their evaluation, I want to know if they ever had physical or occupational therapy before, maybe speech therapy as well. How long and when? Did it work? Did it not? Did they have a home program? Did they do the home program? Did it help or not? And so on. I'm also going to ask them about their medications, their supplements, and their nutrition, because as we just talked about, there can be all kinds of things influencing their health and their well-being, and so the medications can be all over the map with the new standards of care. They're using preemptive cardiac meds, and they could be on steroids, which is important for me to know because we do know about the possible side effects and risks of steroids as well. I also want to know if they're trying to use supplements to maintain a healthier status and to counteract the side effects of the steroids and so on. Nutrition is important to ask about too. What are their eating habits? One of the side effects of steroids that we didn't mention earlier is this predisposition to crave salty foods and sugary foods, and that really can add to the weight gain. And you have people who are already significantly weak and then add extra unnecessary weight to them. It makes life a lot more difficult. So helping them through any nutritional concerns and giving them proper referrals is really important as well. I'm also going to ask them about their safety and their tolerance of their daily routine. So not just are they making it through their day, what their daily routine looks like, is it safe and are they tolerating it? And even more important, not just are they tolerating that daily routine, are they tolerating it throughout the week? Do they look the same way on Monday as they do on Friday? Do they feel the same way Tuesday morning as they do Tuesday after school? So the tolerance of their daily routine is very important, and it's something that we can address if it's not being tolerated. Safety is very important too. We maybe didn't mention earlier, but in that late and transitioning stage especially, falls can be catastrophic. Someone with Duchenne muscular dystrophy can fall, a very simple fall, and fracture a femur, a tibia, lumbar compression fractures. And if not handled well, or if they're not strong enough, they may never walk again once that heals. So it's really important to address safety. Along with safety, and we're talking about tolerance, is talking about pain and fatigue during the subjective evaluation. So pain. Duchenne isn't necessarily a painful condition, but pain can be related to poor positioning or muscle pain from overuse, things like that. But fatigue is something that gets forgotten a lot, and we actually need to ask about fatigue. When they've done some quality of life studies for those with Duchenne, fatigue was significantly correlated to many areas of quality of life. Even when pain and anxiety were present, fatigue was more significantly correlated to poor quality of life. So don't forget about fatigue in asking those questions during the subjective. Sleep patterns, should always ask about that. Sleep apnea is very common with Duchenne, and if not addressed, could cause some behavioral issues during the day, headaches, poor attention span and focus. So even some of the very young guys can do sleep studies to figure out if there is a sleep issue. Education settings, since I don't work in the school district, and many of us don't, important to ask about it. What the education setting looks like, what are the daily routines, how many times do they walk to the field or the library, all of those things adding up, if they have an IEP in place and such questions like that. Also, don't ever forget to ask about those parent and client concerns and their goals to make sure that you're all on the same page, that you're all addressing the same concerns and have the same expectations from the therapy itself. Once you've completed the subjective evaluation, the objective evaluation should include most of these areas at least. Both passive range of motion and manual muscle testing need to be done with care. So passive range of motion, you don't need to do the entire body. Once you get more familiar with the diagnosis, you'll be able to complete the primary areas with more detail and then screen the other areas as needed. And with manual muscle testing, asking someone to produce their maximum strength over and over again is contraindicated. So try to pinpoint which muscles you want to test and make sure everybody's in the correct position and understanding what to do before doing so, so you limit how many times you have to repeat each test. Grip or pinch dynamometry can be used as well and has been shown to be reliable with Duchenne muscular dystrophy. And then I'll go into their functional status, just seeing how they do things, what they're able to do and not do. Gait analysis, I see patients primarily in their homes, and so I do not have a gait lab, but to do an observation of their gait is important, and to note as many of the qualities of it is important as well, so that you can detect change from one evaluation to the next. Respiratory screenings, we talked about the importance of doing some respiratory training and for them to do pulmonary function tests well. So I'll do a respiratory screening just to see how things are going. Ask them to cough or clear their throat to see if they're able to produce that, watch the rib expansion during inhale and exhale. And if I see any problem areas that I'm not able to address, definitely to refer them to their pulmonologist for more information on that. Also, spinal and scoliosis screening. We don't typically have to worry about scoliosis in those individuals who are still walking, but we still screen them to make sure, and then once they become non-ambulatory, it's something that needs to be watched very carefully. They should be screened at hopefully their multidisciplinary clinic appointments every 6 months, but if not, if you see something, then please send them to the right referral source for that. Also, when I meet a new patient, they may already have a lot of equipment. So whatever they do have, I want them to bring it with them. We're going to test if it fits, if it functions right, if they know how to use it, if they know the duration and frequency they should be using at all of those things. There's also a couple functional tests that are pretty standard in Duchenne. We mentioned a little bit earlier about the 6-minute walk test, and that is primarily something that is done in large clinics and hospitals. So if you have the setup for it, there's very specific guidelines to how to set it up, where they will have basically an oval-shaped track where they walk as many meters as possible in their 6 minutes, and there's specific directions you give and so on. The North Star Ambulatory Assessment is available on this site as one of your references. It is a PDF with the full instructions, and it's a very quick and simple standardized test for us to do with Duchenne. It was developed specifically for Duchenne by the Hammersmith Hospital in the UK, and it is just for ambulatory individuals. It's 17 items that are rated 2, 1, or 0, so a maximum score of 34, a minimum score of 0, and you are measuring them according to the directions and then just comparing from time to time. So from one evaluation to the next. So you're comparing them to their own results to see if they've changed, an increase or a decrease in their score. And then the last one is the performance of upper limb. So this was more recently developed as a way to measure the upper extremity function, and it was primarily developed for clinical trials. We needed a way to assess the functional outcomes of some of these clinical trials for those who are non-ambulatory. So the performance of upper limb is a well-designed test with multiple categories, and the upper limb function in the patients, it consists of 21 items, testing the shoulder, the elbow, and the distal upper limb performances. And then they're given a score based on that, and you can measure it from time to time, again, from evaluation to evaluation. And it's also been shown to be reliable as it was developed for Duchenne. So after your evaluation is complete and you're coming up with your treatment plan, which we'll go over a bit of those, your care plan for Duchenne actually has many areas to think through. So setting a frequency for those sessions and consults. The parent education is part of every one of our care plans, not just the parent but the patient themselves, so that they understand what Duchenne is, what the progression is expected, and so that they, when they're not in front of you, can make better decisions for their own self or their own son, so that you've given them the tools they need to make the best decisions when they're out and about. You're going to use interventions to deter progression and specify the home exercise program. So this is one of the many conditions where the home program is vital. It's very important that this becomes part of their daily routine. We're looking for equipment recommendations. So what don't they have at this time that they will need? We'll go over some of those. And modifications for their daily activities. So in subjective, we've asked them, what do they like to do? What do they enjoy doing most? And if we find that any of those are detrimental, this is our chance to offer more appropriate activities, less damaging to the muscles, and to help modify their daily routine. Making referrals to appropriate healthcare providers. So luckily, as therapists, we're not in this alone with our patients. There are many, many types of healthcare providers that are hopefully providing care for these guys, and we can just help make the right referrals when we see that the patient needs it. And then always specify the time that you plan to do reassessment or to modify their plan so that the family knows what to expect, so that your patient knows what to expect. And also, if they happen to be going to reassessments at a clinical trial or at their multidisciplinary appointments, so that you're not doing all these functional tests the day before they're going to that appointment as well. So maybe you can coordinate that a little better. So as far as therapy management for all this flexibility and contractures that we're concerned about, we have to think of first what's causing it. We know it's an imbalance of strength around joints, right? You have one muscle that's weaker than the other. Fibrous and fatty tissue deposits within the muscle itself. So the extensibility of the muscle is not as good as it used to be. Impaired active range of motion. So not only are they getting weaker, it's impairing their active range of motion, so that will in turn significantly affect their passive range of motion through time. And also static positioning. If you have someone who's sitting in one position for too long or laying in a position too long, that can affect their flexibility and contractures as well. So why do we control contractures? We know that contractures interfere with function and they contribute to their disability. We have studies that show us that a loss of range of motion in the lower extremities causes boys with Duchenne to stop walking sooner. And if someone stops walking sooner, they're at a greater risk of developing scoliosis. And someone who develops scoliosis is at greater risk of having cardiopulmonary issues. So it's a bad path for them to go down, starting with their contractures affecting their function. We do know symmetry is important because we did show in that one Canali study that those who had an asymmetry when they were still ambulatory, that asymmetry contributed to a more significant incidence of scoliosis once they became non-ambulatory. And also because contractures lead to loss of independence with their own ADLs, mobility related and activities of daily living related. And so we want them to maintain their independence as long as possible. Contractures also cause pain. We need to be aware of that, like I said, Duchenne is not a painful condition, but contractures can be painful. And to reduce the sores from abnormal pressure, so we're talking about pain and skin issues as well. To be able to rest their feet on their footrests. So it may not be a medically necessary sometimes, but sometimes it does add to pressure sores. And being able to rest your feet on footrests appropriately is a valid concern. To be able to sleep comfortably. If you find somebody, especially if they're in their 20s or so and have Duchenne, they're not able to sleep very well through the night in general. Waking their parents up every 45 minutes or so because they need to get turned. They can't turn over in bed. And then to be able to find a comfortable position if they have hip and knee and shoulder contractures and all of the above, then sleeping comfortably does become impaired. And also just to bathe easier. To be able to, even if they are dependent on someone else, to be able to bathe easier is a concern as well for contractures. I'm going to read a quote from an article by Drs. Skalski and McDonald about limb contractures. And here it is. Limb contractures are a common impairment in neuromuscular diseases. They contribute to increased disability due to decreased motor performance, mobility limitations, reduced functional range of motion, loss of function for activities of daily living, and increased pain. The pathogenesis of contractures is multifactorial. Myopathic conditions, such as this, are associated with more severe limb contractures in comparison to neuropathic disorders. Although the evidence supporting the efficacy of multiple interventions to improve range of motion in neuromuscular disorders in a sustained manner is lacking, there are general accepted principles with regard to splinting, bracing, stretching, and surgery that help minimize the impact or disability from the contractures. So as therapists, our strategies for trying to control these contractures will probably involve things like passive range of motion. It's going to be specific to each client. Although Duchenne typically follows a very predictable progression and pattern, there are still some intricacies for each client, so make sure it's specific to each client. Repeat the parent training. We'll talk about how important the home program is, but definitely when they're there in front of you, repeat the parent training. There's been so many times where when put on the spot or asked, have you been doing the stretches? How are they going? Can you show me one of them? That it comes out that either they weren't doing it correctly or they hadn't been doing all of them or something like that. So just make sure you repeat the parent training because they've taken on a lot with this diagnosis. We want to make sure that they're following through well. And that the home programs are daily. So I always tell my families that it needs to be part of their daily routine to do it every day. And then I really hope that they do it 4 to 6 days a week, which is technically our standard of care in that Bernkrant, as the lead author, that article about the guidelines for Duchenne. So 4 to 6 days a week is what we're looking for, and I'm hoping for every day if it's possible. And that they have more than one person trained. So a lot of times it's, maybe mom accompanied them to the appointment, so I taught mom, but I really want to make sure that dad and the babysitter or the older sibling or grandparents also gets trained so that mom can have the night off every once in a while or that more people are involved in the stretching program. Our basic guidelines for stretching is that it should not hurt. So stretching shouldn't be painful. It needs to be done in a relaxed manner so that it's effective. And if it's painful, then you and him are probably fighting each other, which is not something you want to do with somebody who has a dystrophic muscle. So it needs to be relaxing. It needs to be not painful. Sometimes there's some negotiation when we're getting going on it between what he feels is painful and what I feel is an effective stretch. But we work into getting effective stretches hopefully soon. Maybe it takes a week or so to get used to the. I've had families who have just really battled trying to get the stretches done, and so we've backed off. And I say, instead of doing the full hamstring stretch, just hold his leg. Hold it in somewhat the stretching position, but don't put any stretch on it. Do this, and each day try to do a little bit and a little bit more until maybe a week from now you get an effective stretch. And I'd rather waste a week trying to warm up to it than just have that battle go on or not do them at all. So once the muscle relaxes, I ask them to stretch further. So I'll try to teach the families about that initial resistance they may feel. And after the muscle begins to relax, after the stretch begins to happen, to go into the stretch a little further. And then always observing for the compensations. So in the family training, there is the home stretching program. Like I said, it's specific to each client, and we're going to repeat the training. But if you need a little bit of help, or if they want something to take home with them that shows the 6 most common stretches that we do in Duchenne, we do have a handout that's an easy to print PDF on the website on cureduchenne.org. And we also have a YouTube channel, Cure Duchenne MD. And you can search under that for the physical therapy videos. I believe there's about 20 of them. And the very first one is all about stretching. So you'll have some families that are better learners if they're watching a video while they're trying to do it, or they want to look at a paper that has the written directions. That's fine. Please use those as you need them. Also on the Cure Duchenne MD YouTube channel, we have a video about self-stretching. So I'm holding a device here that is called a Nada chair. It comes in this little pack, and it's only about $50, but this is one of our self-stretching devices, and it's not considered medical equipment, so it's easy to get. You can get it off Amazon. You order it with the Kitty Up straps, and we simply use this. Let me open it up here. So it's got long straps and then loops that go around the feet. And so you'll see in the video how we can use this for a simple hamstring and calf stretch at the same time in a long sitting position. So this can be part of the home stretching program that you send with the family, along with some of the other self stretches that we have on that video on YouTube. And there is the handout as well on cureduchenne.org on the website. One of the other things to do for that home program is just to go over their home activities with them, what a family enjoys doing, what the son enjoys doing the most, and making sure they're not more damaging for the muscles, or offering them other ideas of things that would be more beneficial. Other means for controlling contractures beyond passive range of motion and home stretching program are the use of orthoses. So we'll talk about ankle-foot orthoses, knee-ankle-foot orthoses, hand-wrist orthoses, and thoracolumbar sacral orthoses as well. When we talk about ankle-foot orthoses, or AFOs, for the Duchenne population, we're talking about resting splints. It's no longer recommended that anyone with Duchenne muscular dystrophy walk in AFOs unless it's a very isolated case with a lot of oversight, someone watching the program. But typically, an AFO adds too much weight and becomes too cumbersome for someone with Duchenne to ambulate with them on. And also, especially a fixed AFO, the fixed ankle, it requires too much from the hip and the quads to maintain ambulation, and overworks those muscles even quicker. So we're talking about resting splints. For someone who's ambulatory, we recommend that they're used at night. And for someone who's non-ambulatory, they get to choose whether they'd prefer to wear them at night or during the day. In either scenario, we ask for 6 to 8 hours per day or night, every night of the week, and that's in our standards of care as well. Now, AFOs are used and intended to maintain range of motion, not increase. So we're not going to put somebody in a really uncomfortable AFO and ask them to wear this for 6 to 8 hours while they try to sleep or go about their daily routine. So it's for maintenance, not for increasing. This one here is our DAFO 3.5. This is not a softie, but the softie is in your photo there. So the DAFO 3.5 softie, is the one that we look for because of this wraparound foot design. It gives a lot of control, and we know where the position of the ankle is when they have this much. Some of the off-the-shelf or the other brands where it doesn't have the wraparound on the midfoot, the heel will slide one way or the other during the night or during rest, and then you don't really know what angle you're getting, and you're not getting the control that you're looking for. So we look for something like this that has the wraparound control, has a somewhat stiff upright, and is lightweight. We also recommend this style with the fixed ankle if we have someone where we don't expect their range of motion to change very much. If it's someone I've been seeing for a while, I know what their range of motion is, I don't expect it to change, then I will give them this because of how lightweight and how easy it is to use. We also sometimes use the DAFO 9. This one has an adjustable ankle. So that's the biggest difference is we would use this one, same thing, resting splints and all the same parameters, but I would use this one for someone that I think their ankle range of motion might change. So if I just met them, we're just getting their stretching program initiated, or for some reason I expect their ankle range of motion is going to change, this one accommodates that, so we can change the ankle measures if we need to. The other thing about if you do order, this is also made by Cascade, this is their DAFO 9 Softy, order it with the non-elastic straps because we don't want them pushing into something bouncy while they're resting. We want their calf muscle to be at rest. We do have an article, lead author is Hyde from 2000, that does show in their two groups, they had an AFO plus stretching group and they had a stretching only group. And the AFO with stretch group had 23% less contracture than the stretching alone group. And then all of the functional measures were better in the combination group, the stretching with the AFOs, than the stretching group itself. Knee ankle foot orthoses, or hip knee ankle foot orthoses, depending on how high it goes, can be useful in Duchenne. They can be used for trying to prolong assisted ambulation for therapeutic purposes, but not necessarily for ambulation throughout the home or community, and also for prolonging weight bearing in general and standing. It does take an ideal candidate to use these. That candidate would have to have ideal hip, knee, and ankle range of motion to even be fitted into the device as well. They have to be able to tolerate the activity that's being prescribed, and also to be able to commit 2 to 3 hours per day for this routine of donning the braces, walking or standing for any period of time, taking rest breaks, and then repeating, and then to take the devices off and put them away. So they also need some sort of caretaker that has that time commitment as well to help them with this process. They won't likely use a walker with this, so that caretaker, the person that's with them, will also have to be able to monitor and assist with the walking or the standing. There is a study by Vinyos, which is published and says that subjects with the KAFO program had less than a 5-degree knee flexion contracture after 2 years of a standing and walking program with KAFOs. But the groups without KAFOs or standing at all had an average of 46-degree knee flexion contracture after 2 years. So a very big difference between those two groups over a 2-year non-ambulatory time. Next, we have the hand-wrist orthoses, which can be used with some of the non-ambulatory patients with Duchenne who are starting to experience tighter and tighter long finger flexors or wrist flexion and extension. They may experience it earlier throughout their school years, but it really doesn't take hold or become such a big issue that you need something beyond daily stretching until they become non-ambulatory. And really at that point, their hands have become their gateway to the world because they're not walking through it anymore, they're using their hands. And so we really want to make sure that we're taking great care of their hands. This is a sample of a hand-wrist orthosis that I use very often. This is an off-the-shelf, just ordered as is. It's the Rollian Advanced Orthoses that you see the slide here. I like using this one because it is adjustable. So I can order it for not too much money for my patients. And if you can see, I can bend it if I want more or less at one of the joints. I can do the same thing with the fingers or the thumb. And then it's pretty comfortable. So this works for someone like me who just needs to order something and I don't have a hand therapist or an OT making them for me. But any hand-wrist orthoses that's appropriate would work. You want a resting orthoses. something that they can wear at whatever time of day they decide, daytime, nighttime, whatever works with their schedule. Some of the obstacles that we've run into with using a hand wrist orthoses is trying to find the right time. So obviously, like I just said, these are guys who are using their hands for everything during the day, to operate their chair, to operate their computer, their remote, their phone, everything. And we need to find a time during the day or the night that they can have their hand immobile and using this. So sometimes it would be maybe if they're right-handed, the left hand during the day and the right hand at night, but just come up with what program would work best for them. We do have a very recent study that does show that you can delay the development of contractures in the hand and wrist and the thumb. It's by Weichrodt in 2017, and that in their study they were able to improve the passive wrist extension and thumb abduction in their patients. To qualify for their study, the patient had to already have lost 50% of their wrist extension. So these were patients who already had some deviations from normal, and they were able to actually improve it using the hand wrist orthoses as a resting splint. So moving forward into more aggressive ways of controlling contractures, we can look at standing activities. And it's typically in that late and transitioning stage, and especially in the non-ambulatory stages, that I look at standing activities as a way to help maintain or prevent further contractures. So what I'm hoping that they're going to get out of their standing activity is a passive stretch, and then asking them to do some isometrics while they're up in extension, especially for those who are non-ambulatory or who are late and transitioning in the ambulatory phase, because they're probably not spending very much time in the standing position. And it's really important for them to get in that position, and not only in that position, but well aligned like a stander would do. So we're looking for them to hopefully get better bone health out of the standing activities, and pelvic and spinal alignment as well. So we have two rather recent studies that are helping us to define what standing activities are beneficial and what duration and frequency we should look at. So the Pelig study from 2013 was a systematic review, and it was about all neuromuscular disorders, not just Duchenne, but they benefit mostly in maintaining passive range of motion of the lower extremity and bone mineral density with greater than 45 to 60 minutes per day. So that's what I ask my patients for. And then even more is possibly they benefit even more from adding the vibration possibly, but that needs to be studied further. The other study mentioned is the Townsend, released in 2016. And these are good preliminary positive results for the use of standing in the Duchenne population. So we are starting to get some of the evidence that we need to help get the payers on board with the standing, but we know that there's so many areas affected by Duchenne that can actually be helped by the standing position. So there's all kinds of standards out there. Hopefully you have an equipment vendor that you work with well that can help you see what's new and what's out there, and to help you get your patient what they need. This is a sample of an electric stander. There's hydraulic, and there's all different kinds. Beyond the therapy procedures and those first parts of equipment that we're trying to use to control these contractures, serial casting is a viable option as well. In serial casting, for Duchenne, it's almost the same as what you would see with other populations like cerebral palsy. So you have to be selective with your patients. Not all clients are going to be candidates, especially in Duchenne. You have somebody who's if they're too significantly weak, they're not going to be able to continue ambulating with the serial casts on. So you have to be aware of those types of things before recommending it for someone. And you also should be aware that serial casting isn't a last-ditch effort in Duchenne. If you have someone that you're trying to get them to stretch, trying to get everything working, and you're doing everything and it's just not working, think about serial casting earlier on. If you wait too long, then you have the possibility of running out of time where they can no longer tolerate being in serial casts while they're ambulating. So just think of serial casting earlier on. It is intended to correct ankle and foot equinus contractures. There are two protocols out there. You may hear about an 11-day protocol, which was introduced by the Hammersmith Hospital in the UK. It's in the MAIN study, MAIN. And what they were trying to do is get those with Duchenne out of the serial cast sooner. So the traditional protocol is a new cast every week for up to 4 weeks. And the 11-day protocol, they were trying to get them through that process in 11 days. So they would change the cast every 3 days and try to get more and more dorsiflexion each changing of the cast every 3 days. And their initial studies were actually really good. They did 29 in their serial casting group, and they did the 11-day protocol. Their serial casting group maintained neutral dorsiflexion for 6 months after the procedure. And 4 of those 9 did it for 12 months after the procedure, which are great results, we know, especially in this population. The mean age of loss of ambulation for that serial casting group was the best out of all of the groups they had. Whereas we have a great study too regarding Duchenne on the traditional serial casting. Basically what they found, this is the Glanzman 2011 article, they also had 9 in their treatment group, and they got about a 12-degree increase of dorsiflexion over their 4 casting periods. Both protocols got about 3 to 4 degrees of increase with each cast. So if you have someone that doesn't need a full 12 degrees of increase, they might be able to do serial casting, either protocol for a shorter period of time, which would be great. So in the Glanzman article, they did get that increase with each casting change, and they had no loss of function during the serial casting procedures, which is really beneficial as well. As an example of serial casting, here's a couple photos of some serial casts that we've had come out of the local hospital that really did well. What I like about these ones are they're extremely lightweight. So this young man who was wearing them was still ambulatory and was able to walk his short distances even with the serial casts on. They also made him with a very flat bottom so that it wasn't a challenge for his balance. And some serial casts I've seen have more like a rocker bottom, and we want to try to avoid that if possible. They also obviously decorated them very nicely for him, so they weren't, so they were a little more cool. But they also opened up the area around the forefoot as much as possible to keep his feet from getting too warm. Beyond the treatment techniques that we offer our patients to manage their contractures is referral for an orthopedic consult. This is when they have contractures despite everything that we could do for them, all of our attempts at passive range of motion, home program, orthotics, and that contracture is their limiting factor in function. In our standards of care, we do have it written that surgery for the ankles is recommended, but not at the knees or the hips for the typical patient with Duchenne. And keep in mind, after surgery, physical and occupational therapy especially need to be implemented so that we can make sure that they meet the goals that they set forth in having surgery in the first place. So that we help them keep the range of motion if that's what they're looking for, that we help them maintain ambulation if they were ambulating before surgery as well. In the Journal of Bone and Joint Surgery, there is a study that does show the difference with or without PT after surgery. They had 2 groups, and in one group they had an Achilles tenotomy and bracing after surgery. Their mean plantar flexion contracture after a year was 24.2 degrees. So they basically probably lost all of the benefit that they had received from having the surgery in the first place. Whereas the group that had the tenotomy and bracing and active physical therapy had only a 2.5 degree average contracture in plantar flexion a year later. Besides ankle, knee, hip contractures, those types of things, scoliosis can be managed and hopefully prevented in a lot of cases. The incidence of scoliosis used to be 70 to 90% of those with Duchenne when they became non-ambulatory ended up with scoliosis of some severity. Now, those who are on steroids, the incidence of scoliosis is 15%. So it's a dramatic decrease in the incidence of scoliosis, but it still does exist. And what we need to do as therapists, what we can do with our tools in our toolbox is to help keep the flexibility in their spine. Keep them mobile. Don't let them get stuck in one way or the other. Posture can play a big role in that. But also keeping symmetry of the upper and lower extremities because they do influence the pelvis and the spine. Equipment consultation from as young as those kindergartners. What position are they sitting in the chair? Is there a footrest for their ankles to be at a relaxed angle? What are the hip and knees and spine doing in their seated position? So looking at their seat, desk height, and at home as well. We'll get into mobility equipment, but some choose to use a scooter, and the scooter seating is not ideal at all. So how can we adapt that to better support their hips and spine? Wheelchair seating can definitely include custom seating and custom seating orthoses if those are required, and the sleeping position. So the sleeping position can actually have a really big impression on their scoliosis as well. So one other big driving home point for our role in managing Duchenne is that maintaining safe ambulation as long as possible does help reduce the incidence of scoliosis. On the other side of things, the medical management of scoliosis can involve a thoracolumbar sacral orthoses, although this is seen as a temporary fix for someone who is already having a spinal curvature, who maybe is waiting for tests to come back to clear them for surgery, but it's not really a long-term solution. As we know, it doesn't halt the progression of scoliosis in most cases. Spinal fusion is a medical management and a standard of care for scoliosis with those who have Duchenne, and can be done relatively safely and well, and then just managing their post-op care. We also know that part of medical management of scoliosis now, because of its great efficacy on it, is the use of glucocorticosteroids, prednisone and deflazacort. Things to consider if a patient is going in to have their scoliosis corrected or a spinal fusion is that there will be an extended hospital stay of approximately 14 days, and that they will try to get the person up to sitting a lot of times on post-op day 1, not on day of operation, but post-op day 1, and then progress them from there. The new position that this person is in may make it difficult for them to clear their throat, to cough, and they'll have to do it in different ways than they had before. So monitoring airway and restrictions of those airways and possible infections is of utmost importance during this rehab and recovery phase. The bony prominences are all in different places as well. So if they're up in their typical seating cushion or seating positions, they may have new areas of pressure, and pressure sores may develop. So be mindful and monitor those. Monitoring pain, not just post-op pain, but new pains from pressures as well. Spinal rotation will likely be restricted to 0. Hip flexion limitation will likely be less than 90 degrees. And also, before someone heads in for this type of a surgery, if you're able to, please consult with them about how their body will be different when they come out, what kind of therapy they'll need after their hospitalization, and the fact that use of their arms may change as well. If you have someone who is used to being able to flex their spine to come down towards their hand to feed themselves, they'll no longer be able to do that before, and they'll lose their ability to self-feed. Things like that could be really shocking to someone if they weren't prepared for that. So you can also get things in place ahead of time, ahead of surgery, to make those types of modifications to their daily routine already in place when they get home after surgery. So moving on into areas of exercise, activity, and mobility for our patients with Duchenne. The general rules of activity are you want to eliminate stairs, or at least limit them, hills, running, and jumping, all of those types of activities, because of the demand that they place on the muscles. What we need to state is that those muscles that are prone to damage are even more so during an eccentric muscle contraction. So you want to avoid eccentric muscle contractions at all times in their daily routine. So especially walking downhill, walking downstairs, lowering themselves slowly to the ground, those types of things. You don't want them to do repetitive muscle work to fatigue. So giving frequent rest, decreasing the amount of repetitions. And then the cumulative daily activity in all environments should be taken into account when suggesting modifications or adaptations to make sure that the cumulative activity is going to be okay. The typical PE curriculum, which is based on strengthening and improving activity performance, is not appropriate at any age for Duchenne. It needs to be adapted and modified. Physical and occupational therapy plans and goals are mostly in line with maintaining strength, range of motion, and improving efficiency. Promoting participation in a modified manner or alternative activities with siblings and peers is very important for their social well-being. Energy conservation. It's been mentioned many times in the course about activity intolerance and conserving energy and how important it is to avoid fatigue. So we need to analyze the activities that they enjoy doing and the ones that we are offering to them, and make sure that they're done in a way that is less damaging for their muscles. So let's talk about exercise. Exercise is one of the hot topics, one of the areas that I get most questions in. And to be honest, the research is still getting done to give us exact answers, but we do know a few things that are very helpful. We do need to always take into account that it's a careful individual assessment of each individual patient before you prescribe any exercise. No two patients, even though they have the same diagnosis, are alike. No two stages are exactly alike either. We do know that we need to avoid eccentric exercise. So try not to prescribe anything or try to help them decide on different activities to avoid eccentric type of work. We also want to avoid overuse and disuse. So there's some sort of a line in the middle, which is different for everybody, and there's no formula to find it. You just have to use your observational skills and their feedback to try to find what was too much, what was not enough, and where are we at in between. And probably as soon as you find it, a month or two down the road, it's going to change because their bodies are always changing. But you need to find that midpoint for each of them. And also taking frequent rests. So that's our safe way of, we don't know if it's too much, let's take some rests and reevaluate during the rest and see if it's okay to continue. All exercises and activities that are being considered should always be low load and aerobic. No anaerobic exercise, no power type of activities. We do know that people with Duchenne, from some studies that have been done, we do know that their bodies are capable of reacting to an aerobic exercise. The way the study states it is the same as an sedentary adult who's beginning cardiovascular exercise. So there is a cardiovascular response of their body. We also have swimming and light bicycling to consider. These are both low load and both aerobic type exercises. And Janssen in 2013 was able to publish the No Use is Disuse study. And they did a bicycling study with an upper and lower assisted ergometers. And they had 16 kids with Duchenne who were in that latent transitioning stage in the treatment group, and 13 in the same stage that were in the control group. What they were assigned to do, the treatment group did 15 minutes of assisted upper and 15 minutes of assisted lower bicycle training 5 times a week for 24 weeks. And they measured function and range of motion. And what they found after 24 weeks was that treatment group, who we expected to decline because of the stage that they're in, maintained. They maintained knee extension, dorsiflexion, and elbow extension range of motion, and all of the functional measures that they had been measuring, which over a 6-month period during that stage is pretty phenomenal. And so after doing that, they switched, and now the control group ended up doing the study themselves. So the 15 minutes of upper and lower per day, 5 days a week for 24 weeks, and that group then, they had declined during the initial phase when they weren't doing any treatment, and then once they started doing the treatment group, they stabilized as well. So swimming is actually an activity that I am a big fan of for all populations, even the normal population, the typical population, but especially for those with Duchenne. It is a low load and mostly concentric exercise. It is an exciting way for the kids to socialize with their peers and siblings. It relieves stress on their joints. There are all these compensations and these out of alignment positions that they're in, whether they're sitting or standing. It relieves that pressure that their joints are feeling. There's a respiratory benefit for breathing against the resistance of the water, and then the sensory input for all of us, and especially for those who have the maybe a sensory integration disorder along with it. So swimming is something to look into, to take seriously as a fun and a therapeutic activity to do. And what I love about it too is that once their water's safe, it's an activity that they can do throughout their whole life. It doesn't matter how disabled you are or become, you can still benefit from being in the water environment. And as I mentioned earlier, there is that YouTube channel called Cure Duchenne MD. There is a video about swimming activities on there, and there's also a handout on cureduchenne.org. And you can look at both of those. They're really written as swimming activities, not as aquatic physical therapy. But if you are an aquatic physical therapist or want to recommend it for your patient, they can learn a lot more of the beneficial things that they can do in the water. Besides swimming, there's bicycling. So some families, they love to ride bikes, and they really wanted their son to enjoy this activity with them and with the whole family. And so we know that this is concentric exercise, and we can keep it low load. And so there's just a few things that I help direct the families to get when they're looking into bikes. So some of the things I'm looking for is that they have a low step through, so when they're stepping on and off of the bike, they're not tripping over a high bar, and that the handlebars are up above where their seat is, so their weight is back on their hips and not forward on their arms. When the seat's too high, there's too much weight through their arms. I also like bikes that have the option of either having hand grip or foot brake, so that he can use whichever one he is better with and more safe with. Those are some of the ideas that we look for. And then as things progress, if bicycling is something he really took to and really enjoyed doing, and wants to add an electric component to the bike later on, there's all kinds of electric assist components that you can add to almost any bike, or buy a bike that has the e-assist as well, or even transfer the whole activity into a stationary bike if that's what he chooses to do. These days, there are many types of upper extremity assistive devices, sometimes called robotic devices or exoskeletons. There's a lot of devices coming out and that we hear about and that go away, and some that stick around. So it's a really good option to look into for patients who have Duchenne, especially those who are non-ambulatory and are really relying on their arms and starting having difficulty raising from their shoulder to get arm elevation. To look into these to help them be a little bit more independent with eating, with turning light switches on and off, with using their computer. There's a lot of things that they could probably do better and for themselves if they had some sort of upper extremity assistive device. Some of the benefits to them are those increases in independence and usability of other things around the house, but also as an exercise device. So if you have somebody that can no longer independently against gravity raise their arms upward, but they have a device that is doing like active assistive range of motion with them, and they can get through that range of motion, they may maintain their strength longer, and they may maintain their passive range of motion longer too, because they're getting through a greater range. So think of it as maybe a clinic therapeutic device or an at-home therapeutic device as well, not just an assistive device for activities of daily living. Some of the cons on the devices, and there's so many devices that you'd have to look into each one, but some of the cons are that most of them that attach to the power chairs have been built pretty wide, and it's hard to get in and out of doorways while it's still attached. So they're coming up with some better designs for that, but at this time there's many that are out there that are just hard to use around the house or in and out of doorways. And then also to attach them and take them off, you do need a caregiver or an assistant for those. Many of them aren't funded by insurance, but I know that there's several organizations working on that as well. A great topic for us to discuss is mobility equipment and what types are used and when they're most appropriate. So we have the stages that we're looking through as far as mid-ambulatory stage, late ambulatory and transitioning stage, and the non-ambulatory stages. And we're going to talk about each type of equipment that might be appropriate individually. First, we'll talk about the electric scooter. This is a device that was developed for mainly the geriatric population. They were definitely not developed for pediatrics in mind, but they've become very common for those with Duchenne to use as sort of an intermediate between being too big for a stroller and being pushed around and not being ready or not wanting the power chair yet. So there are benefits of these scooters, although they aren't ideal. There are some benefits. It gives the person mostly independent mobility. So they're not being pushed around in a manual chair, and they're not being pushed around in a stroller. They're able to drive where they want to go. It gives them the means to conserve energy. So maybe a 6 or 7 year old is actually appropriate for a mobility device where they're independent, something like a scooter or a power chair. Well, these two devices would both give them a way to conserve energy, but they also give them a way to get from A to B without using all of their energy to get there, so that when they get there, they're not worn out. So if they want to go play with their friends, by the time they get to their friends, if they had to walk, they may be too tired to enjoy the time. Or if they go on a field trip, they need something to conserve energy so that they save their energy for the good stuff. Scooters are also beneficial because they can be used at a really young age. They're easy to drive, they're easy to learn to drive and to be safe with. A lot of the boys, or maybe even their families, prefer them because they don't look as medical. They don't look like a big power chair. They're much more small and sleek. They can help you with going short distances. So even if you had both devices, a power chair and a scooter, some families choose to just take the scooter because it's easier to just throw into the car and use it for short distances or short amount of time. And they can also be used not just for field trips, for out in the community, to go to Disney World or to go to an event with peers that don't have an accessible home or an accessible area. They can be used that way. Other benefits of the scooter is that they can be taken apart into 5 pieces. Most of them come apart into about 5 pieces and easily put into any vehicle. So you don't need an accessible vehicle or really even an accessible home to use them in most situations. So you're not stuck with, well, he can only go when mom goes because she has the accessible van. They can throw it in grandma's trunk or their babysitters as well. Some of the cons to the scooter is that they don't have particular seating for pediatrics or sizing for pediatrics. You can do some things to make the stem of the seat a little bit shorter so that their feet can reach, or so that they can reach the tiller a little bit better to steer from. You can adapt the seating a little bit to give them better postural support, but it's all kind of thinking out of the box and adapting it on the fly or whatever you can think of. And also, I would say one of the cons of the electric scooter is that it's hard to transition for most of the boys from their scooter to a power chair because they get very attached to the scooter and it's hard for them to see the benefit of going to power chair at that time. So then there's also the manual wheelchairs. So scooters are electric, manual wheelchair are not. They do have benefits. The manual wheelchairs are typically pretty lightweight. They have a folding option, which again means you can put it in just about any vehicle. You don't have to have an accessible vehicle. You can get them in and out of somewhat inaccessible places by doing tilt and getting someone up over a curb or a threshold, those types of things. They can also come with things like tilt in space, which can help with seating and comfort and postural support. They also have the ability to accommodate more aggressive seating. Instead of just, the seat back and the seats like on a scooter, you can actually put a seating component onto a manual wheelchair that's needed. There's also options of doing a power assist or some sort of a joystick assist for driving them. Manual wheelchairs are typically for someone who's self-propelling, are typically a very short or temporary thing because it is still wearing on the arms. Some of the power assist options out there now are almost void of effort. So as soon as they get to that point, maybe a manual wheelchair with an electric assist is a good option for some because they need it to be more accommodating to their home and their vehicle. But it really needs to be power assisted for a manual wheelchair to be appropriate for someone who wants independent mobility. And then there's power wheelchairs. And we could talk about power wheelchairs for a long time. Hopefully you have some experience with them and ordering them for all diagnoses. But within Duchenne, what we're looking for is power wheelchairs need to be thought of when walking has become too cumbersome, not just when they've lost their ability to walk, but when things are getting too difficult or too unsafe, it should already be in order because we know how long the process is of deciding on the right one, getting it authorized, getting it delivered and fitted and so on. So think way ahead. If you start to see they don't have anything yet and they're entering into that late and transitioning stage, get the process started by all means if you haven't already. But anyways, the indications of power wheelchairs is when walking has become too cumbersome or too unsafe, and also when they're missing out on things. So if they have a manual chair that they're not operating very well, if they're still trying to walk everywhere but they're not getting places fast enough, they are missing out on a lot. And even though they may not see the benefits of getting a power chair right away because they have all the negatives in their mind, once they're in it and they're zooming over to meet their friends and to go do things that they wanted to do all this time, they really kind of see the light. Some of the benefits of power wheelchairs are definitely because of the supportive seating. We need that seating to be supportive and also to allow them to be mobile. And then the chairs themselves have so many different power seating positions they can be in, and not just sitting. There's also the standing positions as well. So some of the options to be considered in power wheelchairs is definitely custom seating. Not all of my patients need custom seating right away. They can deal, a lot of the major manufacturers have come out with really good seating as the standard seating on the chairs. But keep an eye on them, see when they are going to need to change it out to something more adaptable, more custom. They can also come with these power seating options. The seat elevator sometimes gets denied by insurance, but consider it. Think about the things functionally, because we need to keep in mind the mobility related ADLs. And does a seat elevator change those? Is he someone who has good use of trunk and upper extremities, and he'd be able to prepare a meal if he were to be able to elevate? Can he reach the microwave if he has a seat elevator, but he can't without it? Can he brush his teeth better with a seat elevator? Those things. Consider the seat elevator if it's a functional increase that you're able to find. There's also safety concerns. So if you have a young man who's going to college or has to park in parking garages and cross streets at night because class just got out, being elevated makes you more visible and is a safety concern as well. There's also elevating leg rests. So we talked about long sitting for some of the younger guys for their self stretches, but to have elevating leg rests not only helps you with circulation and for when you're reclined to elevate your legs, but you can also do a long sitting stretch the hamstrings and the gastrocs at the same time using the power chair. Power tilt and recline should be combined and should both be present on a power chair. They will be used, even if when the chair is initially ordered, maybe tilt is only seen as being relevant. Think about what recline can be used for and the combination of tilt and recline, and there's a lot of benefits to both, and all of those functions will be used. And then there's the standing component. So there's a few manufacturers that make a standing power chair, and just like we said earlier, standing is a modality that we need to use to help control contractures, to try to improve bone health and so many other things. To have a separate stander from the power chair is very difficult on the individual and on the families, and the follow through becomes very low. To have a separate stander, you have to do significantly more transfers. He has to wait until someone is available to help him, and they have to have the time to wait while he stands is 45 to 60 minutes and then gets back in the chair. And the frequency of standing is very low when it's not built into the chair. So the benefits of having the stander is definitely all the medical benefits and the range of motion and the GI, everything, bone health, but also the fact that he has control over when he stands, how often he stands, how long he stands for. If he stands for function, so again, around the house, at school, in the community, if he can use that stander as function, then he gets benefit and function at the same time. So consider the stander in power chairs, and if you have trouble getting it approved, if your letter of medical necessity needs some work, contact me if you can through this. You'll have all my information. Contact your vendors and your manufacturers as well, because they're the ones that got me on the right track, and they can help you as well. Beyond standing power chairs, if we have someone who's in that seated position all day long and they need better support, then there is custom seating. So some of the custom seating that I've seen has worked wonders for my kids, my young adults, and we've had to order at a certain point where we could tell the spine needed more support, and without it, we are looking at the possibility of an increased scoliosis. They almost all have one that's developing. So we can put them in like an orthosis type seat and try to give them all the support that they require. So now let's put it all together. We're going to talk about the interventions that we would apply to the different stages of Duchenne. The first stage that we're going to talk about is our early ambulatory stage. This stage, you can't emphasize it enough. It's very important to educate the parents on Duchenne, on the pathology of it and on the progression of it. So we're talking early ambulatory. These are our young guys from newborn to our 5-year-olds. Let's talk about them. We want the parents to understand what Duchenne is as well as they can, so that when they're not in front of us, they're making the right decisions for their son. So that we've given them the information when they go to that birthday party this week and they know which activities, the jumper or the painting, that their son is going to do more of. So they have that tool taken with them because we've given them the education. Activity modification. So again, we're looking at their daily routine. We need to modify their activities to make sure that their day-to-day fun, because they're kids, is within the means that we want them to function in and not causing more damage or overuse of their muscles. Peer interaction and the preferred activities, look at those as well. What do they like to do with their friends? Do they play video games or do they all play soccer? And what can we do to make sure that they're not just sitting on the couch all day on our disuse side and they're not active running around all day long? And then we're going to initiate their home program and their stretching. Some of the younger guys, they may only have 1 or 2 areas that need to be addressed by a formal stretching program. And I'm only going to give the families what's reasonable, because I know stretching is going to be a lifelong task and activity for them. And I don't want it to make it too overwhelming at this point. So I will give them the 1, 2, or 3 stretches that they need at this time. Teach them how to monitor some of the other areas, just in case I'm not going to see them very often, but give them a couple to do so that it becomes routine and it's not too cumbersome to start with, but they can start a routine out nicely. They can also begin using their AFOs at the early ambulatory stage. So I've had as young as 2-year-olds, because the family was on board and that's what they wanted to do. They started their AFOs very young. I'd say by 4, 4.5, all of the boys with Duchenne should be in AFOs, so that you're stopping contractures before they even begin. We want to maintain good range of motion, not try to battle it once it's already an issue. And it's a lot easier to introduce an AFO, a night splinting program, when there isn't a restriction already. We want it to be a nice and easy, adaptable thing that they're going to do. And we have to come up with all kinds of routines to go over. Sometimes the boys take to it right away, it's not a problem at all. And other times the families choose, well, he's not letting us put him on, so we're going to wait till he goes to sleep, and then we can put him on without him knowing. Or he doesn't like having both of them on, so we're going to do one night and one the other night until we can work up to doing both of them all night for 6 to 8 hours a night. Also, at this age, it's a perfect time to introduce them to swimming and cycling. See what they take to more. Definitely get them water safe during this time period, and then it's something they can develop and grow on throughout their life. And if they enjoy cycling, start out with something very basic, not racing their brother and sister and riding up hills and doing all of that, but fun cycling on flat ground, solid ground with a adaptable bike would be great. And then one other concept that we can introduce at this point is self-awareness. So these young guys, they deserve the credit for knowing their own body. They may not know how to explain it to us, though. So we can start giving them a scale. You had fun yesterday. You went to that birthday party. Did you feel great? Did you have to rest a little bit? Or were you exhausted and sad, or something like that? Just something that they can understand at whatever age they're at, so that they can start being aware of identifying how they feel and giving them words to help explain it. Start it very young so that they're more aware of it when they get a little bit older. At this point, we're going to start discussing some patient case scenarios. These clinical case studies are based on the similar findings of multiple patients with similar presentations. It is very common for individuals with Duchenne muscular dystrophy to experience similarities as they progress through the stages of Duchenne. The strength of these case studies is that these situations, scenarios, interventions, and outcomes are very common and pertinent to many physical therapist caseloads. The strength of the approaches to interventions in these cases are that they are evidence-based, just as they were presented in the course. In a rare disease diagnosis such as this, the evidence available is minimal, but we can base our decision-making on what we do have. According to the Sackett hierarchy of evidence, the quality of the evidence presented by case studies is poor. The highest level of evidence in this hierarchy are systematic reviews and randomized controlled studies. Even though the strength of evidence for case studies is very low according to the Sackett's hierarchy of evidence, in this course, the case study interventions are chosen based on evidence that was presented during the course. The vast majority of this evidence is much higher, including some systematic reviews. You can follow along here for case study 1, Michael. The subjective evaluation. He is 6.5 years old. He was diagnosed with Duchenne muscular dystrophy at age 4.5. There's no other medical diagnoses at this time. The medications he's currently on is deflazacort and lisinopril, which lisinopril is a cardiac medication. He's a second-grade student with an IEP in place. The school psychologist reports mild learning disability and decreased focus on task. Right now he has PT and OT on a consultative model, and there is no PE plan in place. His home program is 2 days a week. He does calf and hamstring stretching and has no durable medical equipment at this time. Socially, he's very energetic. He enjoys playing soccer, video games, and going to the beach. The objective evaluation. Passive range of motion. His upper extremities were all within normal limits except mild long finger flexor and forearm supination tightness. Lower extremity. Hip adduction, bilateral 10 degrees. Hamstring length, right -30 degrees, left -20 degrees. Ankle dorsiflexion with the knees extended. On the right was 5 degrees and left is 12 degrees. Strength and function. For manual muscle tests, an overview of that. Hip extension was 3+ out of 5. Hip abduction is 3 out of 5. Knee flexion, 4 out of 5. Knee extension, 4 out of 5. Trunk extension, 4 out of 5. And trunk flexion, 3 out of 5. All upper extremities were greater than or equal to 3+ out of 5 at this time. His 10-meter run time was 4.2 seconds. Supine to stand time was 3.0 seconds, and to ascend 4 steps was 3.2 seconds, which he did with one handrail and taking reciprocal steps. The score on North Star ambulatory assessment is 27 out of 34. Here are the intervention categories that we have discussed in this course. Some apply to this patient. Please pause the video while you fill in the categories on this worksheet based on the patient case. Let's go over the interventions for each category, as presented in this course. For passive range of motion, the patient requires a daily home stretching program and needs to include more areas than it currently does. The NOTA chair would also be recommended to prescribe a long duration static stretch to both the hamstrings and the gastrocnemiae. Orthoses would be recommended. He requires nightly use of AFOs, 4 to 6 nights per week for 6 to 8 hours per night. Recommended setting is approximately 5 degrees of dorsiflexion. For serial casting, he may not yet be an appropriate candidate for this. Monitor it closely, especially the right ankle dorsiflexion. Stander, not an appropriate referral yet. Introduce this when he is in the late ambulatory stage would be more appropriate. Family training and modifications. The family would benefit from diagnosis education and preferred home activity modification for soccer and beach play. Energy conservation. Patient needs to take frequent breaks during activity to conserve energy and maintain safety during activity. He will require adapted PE and recess participation. For exercise, swimming and pool activity would be a recommendation to increase his amount of play in a safe manner and to not overuse his muscles the way his preferred activities could. Also, swimming has benefits for his respiratory system. Mobility equipment. He requires a means of power mobility in order to conserve energy and move with safety over long distances, variable surfaces, and around other people and obstacles. 2 of the minimalist options would be a scooter or manual wheelchair with electric assist, and the full option would be a power chair. For seating, supportive sitting, he would likely require mild modifications to his mobility device, as well as his school desk, since much of the day will be spent in these 2 chairs. He still has plenty of active mobility to position himself and do pressure relief. Upper extremity assist would not be appropriate yet. Respiratory intervention, you could begin respiratory games and breath stacking training. Swimming could provide respiratory benefits as well. Patient and family education on the importance of pulmonology physician referral at this time. This patient was diagnosed at the known average age of diagnosis for Duchenne. In the 2 years since diagnosis, he and his family appear to have initiated some proactive measures for inflammation, cardiac, and minimal contracture management. They would benefit from a more appropriate contracture prevention plan. They could also use more information on the pathology and how that applies to activity choice or modification. A more thorough home and IEP plan would benefit this patient in energy conservation, flexibility, and safe participation. The ultimate goals of physical therapy at this time would be that the patient and his family are proficient in the daily program, including energy management, safety, stretching, and splinting routine. The desired outcome would be maintenance and increased range of motion in particular areas, tolerance of daily routine with the new modifications. Family would also be able to demonstrate appropriate understanding of the disease pathology and needs by making more appropriate choices for physical activity and a mobility device. Now we'll talk about intervention for the non-ambulatory stages. Luckily, gone are the days that I used to hear, well, he's not walking anymore, so we discontinued therapy. We know now that this non-ambulatory stage can last the longest out of all of them. Luckily and fortunately, many of these guys are living longer and fuller lives, and we have the ability to help direct some of that so that they can access their environment and they can be as independent as possible through this stage. What we're going to continue to do as far as our interventions are assess the spinal mobility and stability. So we want to make sure there's mobility in the spine, that he's not getting stuck in one position or the other, but also the stability. Just because someone loses their ability to walk doesn't mean they can't sit upright anymore, but those muscles will deteriorate. So we make sure that they have good sitting balance when they become non-ambulatory, and then further down the line when they get mid or late non-ambulatory, that they're still able to be stable in their seat, and if not, that we're accommodating it with their seating. We definitely are increasing their upper extremity stretches in their home program. So their pectoralis, their shoulder flexion and rotation, elbow extension, forearm supination, and wrist and finger extension. All of these areas become much more effective when somebody becomes non-ambulatory. You may have noticed for years when they were ambulatory that you didn't have to do much in the upper extremities, but within months of becoming non-ambulatory, all of these areas start to become more and more involved. You definitely don't forget about the legs. You want to continue and increase the lower extremity stretches as well, as much as they are needed. And then continue that use of the stander. So if you were able to get it started in that late and transitioning stage, continue the use of that stander at this point as well. And then pain management if needed. Also, the equipment section of this stage could go on and on. This is their way of living, their access to their environment and their life. So we have to make sure we have it all working just right for them. So lots of planning and fitting and training goes into this. For the power wheelchair, for the resting AFOs, which they can wear daytime or nighttime, resting handsplans, really trying to come up with a routine that's going to work for that, because you can't just say, oh, he'll wear it at night too. I mean, he may have AFOs at night, he may have breathing equipment at night as well, and also having trouble sleeping. So coming up with the right formula for that. Assistive technology, it's growing day by day. There's so much out there and it's getting better. And all the Bluetooth things that our phone can do, there's so much assistive technology to help get them access and operation of their home and their environment. And this is for home, school, community. There's lift systems that need to be considered. So a lot of families continue to like to do the lifts themselves, which can be done safely, done right. But lift systems really are called for at this point to make sure everybody's maintaining their safety. There is a statistic out there that I'm not recalling at the moment, but the take-home message is that most fractures for those with Duchenne happen during transfers. And you got to think too, the caregiver's getting injured too. So everybody needs to stay safe and use lift systems as much as possible. Bathing and toileting equipment becomes more cumbersome, but more important at this point. And continued use of that stander, like we said earlier, and then the bed options. So there's all kinds of different beds that are going to work better. Some are electric. There's alternating air mattresses. There's different positioning cushions. There's fully electric beds that do it all for themselves. But there's a lot of options out there. You got to find the right one that's going to work for him for a long term. Case study 2 is Kyle. He's a 12-year-old boy diagnosed with Duchenne muscular dystrophy at 2.5 years old. His current medications are deflazacort, losartan, Prozac, human growth hormone, and Fosamax. His DEXA scan results indicate osteopenia. Cardiac results show decreased ejection fraction. Pulmonologist recommendations are cough assist to be used daily for exercise. He has AFOs for both legs, wears them 8 hours per night, about 3 nights per week. He's falling often, 1 or 2 times per day, and has a history of 1 year ago post lumbar and left tibia fractures from a fall. He tolerates approximately 5 minutes of standing and walking a few times per day. He has a motorized scooter for outdoor use and ambulates indoors at home and school. His objective evaluation. Passive range of motion. He has bilateral hip extension of -10 degrees, bilateral hip adduction of 5 degrees, hamstring length on the left -35 degrees, on the right -25 degrees, ankle dorsiflexion in knee extension. On the left is -5 degrees, on the right is -13 degrees. Bilateral forearm supination of 60 degrees, bilateral long finger flexor tension approximately -45 degrees at the distal IP joints of fingers 3 through 5 with the wrist in extension. Manual muscle testing, hip extension 2 out of 5, hip abduction 2+ out of 5, knee flexion 3+ out of 5, knee extension 3+ out of 5, trunk flexion 2 out of 5, neck flexion 2+ out of 5, shoulder flexion 3 out of 5, shoulder abduction 3 out of 5, elbow flexion 3+ out of 5, wrist extension 3+ out of 5. His North Star ambulatory assessment score is 12 out of 34. For time tests, he was unable to rise from the floor and unable to ascend 4 steps, but his 10-meter run time was 8 seconds. Please pause the video while you fill in the categories for interventions on this case study. Interventions according to best practice evidence presented in this course. Passive range of motion. The patient needs daily stretches for upper and lower extremity. In orthoses, I would increase the frequency of his AFO use and possibly trial of wrist and hand orthoses for resting position. Serial casting, recommending an orthopedic consult for that. Stander, initiate due to decreased duration and frequency of standing per day. Optimally, power wheelchair with standing component would be good. Family training modifications, power wheelchair consult, home modifications as needed, fall prevention, and proper transfer training. Energy conservation, to reduce fall frequency and risk of fracture, also due to cardiac compromise. In exercises, some options would be aquatic, seated bike without resistance, active range of motion, upper and lower extremities, mobility equipment, recommend power wheelchair with tilt, recline, and standing. For seating, he needs to be assessed for his seated posture, pelvic asymmetries, leaning, and spine curvature, and seating supports. Upper extremity assist would not be applicable yet at this time. Respiratory intervention, teaching breath stacking, and reviewing the importance of pulmonary office follow-up visits. The outcomes discussion. This patient was diagnosed at a relatively early age compared to what is typical with this diagnosis. He has had the advantage of starting early on preventative medications, has started using AFOs, and is using a mobility device to conserve energy. Unfortunately, he is experiencing frequent falls, has a history of fractures from falling, is not on stretching routine, and is not using his AFOs to the recommended dosage. He has a mobility device that is possibly inadequate for his needs and is in the lower extremity weight-bearing outcomes discussion. This patient was diagnosed at a relatively early age compared to what is typical with this diagnosis. He has had the advantage of starting early on preventative medications, has started using AFOs, and is using a mobility device to conserve energy. Unfortunately, he is experiencing frequent falls, has a history of fractures from falling, is not on a stretching routine, and is not using his AFOs to the recommended dosage, has a mobility device that is possibly inadequate for his needs, and is in lower extremity weight bearing very little each day. The anticipated outcomes in this case would be for this patient to be able to limit injury and muscle damage by conserving energy and increasing safety with mobility. Areas will need to be addressed to maintain or possibly increase passive range of motion, use a more appropriate mobility device, increase tolerance, and use of the orthoses. Case study 3 is Wayne. Wayne is 20 years old, a college student, lives on campus, and has personal care attendant team 24 hours per day. He was diagnosed at 4.5 years old, had loss of ambulation at 9 years old. His secondary diagnosis is cardiomyopathy with decreased ejection fraction and respiratory insufficiency. He uses daytime and nighttime non-invasive ventilatory support and a cough assist for daily exercise. His current medications are for cardiac, and he is steroid naive, which means he's never used steroids. He complains of pain in the spine and right ischial tuberosity, complains of fatigue and decreased sitting tolerance in his power wheelchair of less than 4 hours, which is affecting his college attendance. His home program right now is power wheelchair use for the power seating, options to change his position. His personal care attendants assist with passive range of motion of his hands, knee extension, and ankle dorsiflexion, and his aquatic program has been discontinued. For passive range of motion, a general overview is that bilateral upper extremity, shoulder flexion 150 degrees, abduction 150 degrees, elbow 15 to 130 degrees, supination on the left 25 degrees, on the right 20 degrees, and he has decreased extension of all digits at the interphalangeal joints. Manual muscle test, general overview, bilateral upper extremity proximal joints is 2 and 2+ out of 5, middle 2+ out of 5, and distal 3 out of 5. His Brooke upper extremity scale score is 5. Please pause the video while you fill in the categories for his interventions. Interventions according to best practice evidence presented in this course are for passive range of motion, increase number of joints addressed with passive range of motion, and check that frequency is 6 days per week. Introduce soft tissue massage for the personal care attendants to add to the home program. For orthoses, we recommend ankle-foot orthoses 6 to 8 hours per day, resting hand-wrist orthoses 2 to 3 hours per day. Serial casting, we would need to gather more information to determine. For stander, we would also need to gather more information to determine the recommendation. Family training and modifications, we would review current home program, redo training as needed, and add elbow extension and forearm supination. Energy conservation, increase sitting tolerance by using tilt and recline more often. Exercise, active assisted range of motion for upper and lower extremities, aquatic physical therapy referral, and find out why the other one was discontinued. For mobility equipment, we would need to assess the fit and function of his power wheelchair and use of power seat functions. For seating, we would need to do a seating assessment for recommendations for increasing his sitting tolerance, possibly a custom seating option, and know whether pain is new onset or chronic. For upper extremity assistive device, I would recommend demo devices appropriate for his occupation, for ADLs, for feeding, and active assisted exercise. Respiratory intervention, I would monitor his exertion during therapy. Outcomes discussion. This patient was diagnosed with Duchenne over 15 years ago. At that time, the standard of care was not well established, and the use of steroids and other preventative measures were not typical. This patient stopped walking at the age of 9 years old and since has maintained some use of his upper extremities. He has many interventions in place, such as personal care attendants, ventilatory support, power wheelchair with power seat options, although is still having difficulty at his occupation as a college student. The anticipated outcomes for this patient would be to modify some of his current program in order to appropriately address more areas such as range of motion, proper seating support, personal care attendant training. Possible additions to this program would be trials of upper extremity assistive devices and reinstate aquatic therapy. All of the interventions would have the anticipated goal of greater tolerance of upright sitting and use of upper extremities to complete the daily routine for his current occupation and daily living. I hope the case studies help you determine what interventions you will use with your patients at all of the stages. Like I said a couple times, it's a very individual assessment that leads to your interventions, and you're not in it alone. There's all kinds of healthcare referrals. If your patients haven't received them from someone else, then you can help them too. Duchenne does require comprehensive care, and here's a long list of just some of the people that might be involved in it and that you could reach out to help them. If you or one of your patients needs more resources, there are many available on the cureduchenne.org site. In general, it's full of a lot of resources for the families that you serve and for you as well. There's also handouts available. You can download the PDF to have a nice clean copy of the 6 most common stretches used in Duchenne, some of the self-stretches that we use for that certain age of boys who can monitor some of their own stretches, although these would not replace passive range of motion. There's also a handout about swimming activities, functional and fun and stretching activities to do in the water. We also have a handout about massage techniques, do-it-yourself at-home type of massage techniques to help with the circulation and the elongation of muscle. There's a YouTube channel. If you look up Cure Duchenne MD, you should find plenty of videos about educational topics in general, and then also about 20 or so videos about physical therapy for Duchenne as well. If you're looking for research updates, there is a lot going on in the Duchenne space. There are many pharmaceutical companies and research laboratories at universities that are very interested in Duchenne and are doing everything they can to get these new ideas into trials and trying to help treatments and cures. If you're looking for most recent information, you can go to cureduchenne.org under the research index and find information there, and it might blow your mind how much is actually happening and how many areas they're trying to treat this disease. There's also a clinicaltrials.gov, which you might be interested in looking at, or might be helpful to give this information to families that you work with. You can go onto clinicaltrials.gov, put in Duchenne, and it will show you all the clinical trials that are going on right now and which ones are recruiting and what the inclusion-exclusion criteria is for each of them.